Mrs. Nurul Hidayah, Master of Health. The Honorable Vice Rector for Administration and Finance, Mr. Rizka Himawan, Master of Psychology. Mrs. Xin-Hua Kuo, Convener, Taiwan International Healthcare Training Center, and all participants. In the name of Lord, today we are gathering virtually in our fourth international webinar series on nursing at University of Muhammadiyah, Kudus. Singing National Anthem of Indonesia Raya, ladies and gentlemen, please all rise. Ladies and gentlemen, please sit. Reciting the Holy Quran to Miss Naili Nazuli. The floor is yours.
Assalamualaikum warahmatullahi wabarakatuh. A'udzu billahi minasy syaithanir rajim. Bismillahirrahmanirrahim. Ya ayyuhalladzina amanu idza qila lakum tafassahu fil majalis fil majalisi fafsahu yafsahillahu وإذا قيل انشزوا فانشزوا يرفع الله الذين آمنوا منكم والذين أوتوا العلم درجات والله بما تعملون خبير. Sadaqallahul azim. Wassalamualaikum warahmatullahi wabarakatuh.
Opening remark from Rector University of Muhammadiyah Kudus to Mr. Rusnoto, Master of Epidemiology. The floor is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahilladzi arsala rasulahu bilhuda wa dinil haq liyudhhirahu ala dini kullih wa kafa billahi syahida. Asyhadu an la ilaha illallah wa asyhadu anna Muhammadan abduhu wa rasuluh. Allahumma shalli wa sallim ala sayyidina Muhammadin wa ala alihi wa sahbihi ajmain, amma ba'du. The Honorable all speakers, Prof. JIN-RU PhD from National Taipei University of Nursing and Health Science Taiwan, the Honorable Dr. JEYA DEVI COOMASAMY, Education Consultant and President of Infusion Society Malaysia, the Honorable Ms. Anny Rosiana Masithoh, Master of Nursing, Mental Nursing Specialist from University of Muhammadiyah Kudus, the Honorable Mr. Sukarmin, Master of Nursing, Surgical Nursing Specialist from University Muhammadiyah Kudus, the Honorable Vice Rector for Academic Affairs, Ms. Nurul Hidayah, Master of Health, the Honorable Vice Rector for Administration and Finance Fair, Mr. Rizka Himawan, Master of Psychology, the Convener of Taipei Hospital and Taiwan International Healthcare Training Center, and all participants. Ladies and gentlemen, firstly, let us praise be to Allah Subhanahu wa Ta'ala, the Lord of the world, and the sufferer is for those who keep their duty unto Him. Fathers, there will be no hostility except against wrongdoers. Secondly, salawat and salam is sent Honorable Prophet Nabi Muhammad sallallahu alaihi wasallam, his family, all his disciples, and those who follow them in goodness till the day of judgment. On the occasion of the fourth webinar of nursing, I would like to express our deepest respect and appreciation to the extraordinary and life-saving work that nurses do every day. Often under very challenging circumstances, today the theme for an international webinar is elderly nursing care. Ladies and gentlemen, the information elderly in the world, the global population of elderly in the world is 60 years or over numbers 962 millions in 2017. More than twice less as in 1980. The number of older person is expected to double again by 2050. In 2030, older persons are expected to outnumber children at under age 10, 1.41 billion versus 1.35 billion. The number of persons as 80 years or over is projected to increase more than threefold between 2017 and 2050, rising from 137 million to 425 million. Although the process of population aging is most advanced in Europe and in the North America, where more than 1 person in 5 is 60 or over in 2017, the population of other regions are growing older as well. In general, older women are more likely than older men to live long. But in Africa, Europe, older women were more than twice as likely as their male counterparts to be living alone. Data for 67 countries indicated that older persons have become more likely in recent decades to live independently. Based on data United Nations 2017, the number of persons start 2017 until 2050 is already increased. The number of persons aged 60 years in 2017 is 962 million, and in 2050 is 280 million. The percentage increase of them are 116.2%. The highest number of persons around the island in the world is in Asia since 2017 until 2050. The percent increase is 130 and 131%, with 549 million in 2017 and 12 and 73 in 2050. Situation of older people in Indonesia. Indonesia has the 5th largest elderly population in the world. In 2012, there were near to 21 million older people. Life expectancy has increased from 45 in 1970 to 69.2 for the males and to 23.6 for women in 2018. By the year 2050, all person aged 60 plus in Indonesia will reach 21.1% of the total population. Statistic of Indonesia population of elderly. The population is 60 and above on 2018 is more than 27 million, and 2050 is more than 69 million. The elder person living alone is 60 and above percent of total population is 60 plus on 2018 in 8.5%. Older women is 60 plus as a percentage of the total population on 2018 is 5.32 and on 2050 is 11.45%. dependency ratio. The dependency ratio of men and women more than 65 years and old is 5.04%. It means that for 100 productive people have to support 51 unproductive people. I believe that by participating in this international webinar, we are in the right place and the right time. I declare that this conference is officially opening. Yeah, thank you very much for all attention and collaboration. I end. Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh. Welcoming remark from Vice Rector for Academic Affairs to Mrs. Nurul Hidayah, Master of Health. The floor is yours.
Assalamualaikum warahmatullahi wabarakatuh. Alhamdulilladzi hadana li hadza wa ma kunna linahtadiya laula an hadanallah. Asyhadu an la ilaha illallah wahdahu la syarikalah. Allahumma shalli ala Muhammad wa ala ali Muhammad. Wa may ya'tasim billah faqad hudiya ila siratal mustaqim. Amma ba'du. The Excellency Rector University of Muhammadiyah Kudus, Mr. Rusnoto, Master of Epidemiology, the Honorable all speakers, Professor JIN-RU, PhD, National Taipei University of Nursing and Health Science, Taiwan, Dr. JEYA DEVI COOMASAMY, Education Consultant and President of Infusion Nurse Society Malaysia, Mrs. Anny Rosiana, Masithoh, Master of Nursing, Mental Nursing Specialist, University of Muhammadiyah Kudus, Mr. Sukarmin, Master of Nursing, Surgical Nursing Specialist, the Honorable Vice Rector of Administration and Finance Affairs, Mr. Rizka Himawan, Magister of Psychology, the Convener of Taipei Hospital and Taiwan International Healthcare Training Center, and all participants. The first praise be always to the Lord Allah Subhanahu wa Ta'ala, who has given us so many gifts and health till we are able to participate in this international webinar today. It is a routine event held every year with other universities that have collaborated by MOU. This activity is a follow-up to the MOU agreed. This year, University of Muhammadiyah Kudus held an international webinar, which is it divided into several sessions, namely 1. Nursing International Webinar, Part 1, June 26, 2021. 2. Pharmacy International Webinar, July 10, 2021. 3. International Midwifery Webinar, July 24, 2021. Nursing International Webinar, Part 2 today. Today, there are more than 600 participants from Indonesia, Taiwan, Malaysia, Mongolia, Cambodia, Filipina, India, UK, Armenia, and Vietnam. This activity held from June to Agustus 2021. This activity is the first step to that. We hope that other activities can be carried out together, like joint research, student exchange, lecture exchange, and other academic activities. Thank you. Hopefully, this webinar will be useful for all. Wassalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, now please enjoy the video profile of University of Muhammadiyah, Kudus.
Universitas Muhammadiyah Kudus berada di kota Kudus, Jawa Tengah. Bermula dari penyelenggaraan SPK, Sekolah Perawat Kesehatan tahun 1984. Kemudian di tahun 1998, SPK konversi menjadi Akademi Keperawatan A.Kep. Di tahun 2004, berubah bentuk menjadi Akademi Kesehatan A.Kes dengan penambahan Akademi Kebidanan. Lalu menjadi Sekolah Tinggi Ilmu Kesehatan Muhammadiyah Kudus, Sp.Kes di tahun 2009. Dan pada tahun 2018, akhirnya berubah bentuk menjadi Universitas Muhammadiyah Kudus. Sebuah perjalanan panjang untuk mewujudkan universitas yang unggul, islami, berwawasan global, dan berjiwa entrepreneur.
Assalamualaikum. Waalaikumsalam. Selamat datang di kampus Universitas Muhammadiyah Kudus. Perkenalkan, nama aku Rizky dari S1 Hukum.
Aku Andin dari S1 Farmasi. Nah, kalian pasti udah lihat pintas dari kampus ini kan? Nah, ini kampus 1, letaknya di Jalan Ganesha 1, Purwosari Kudus. Nah, kalian juga harus tahu, umku juga punya kampus 2-nya loh. Letaknya nggak jauh dari sini, yaitu di Perbatasan Lor, Jalan Kudus, Jepara.
Di sini, kalian tidak hanya belajar untuk mengasah ilmu pada bidang masing-masing, namun juga untuk merajut masa depan yang lebih pasti.
Betul, dengan pengajar yang profesional, berpengalaman, serta ditunjang dengan fasilitas yang lengkap, kalian gak perlu ragu lagi untuk kuliah di sini.
Kak, kita bisa tahu lebih banyak lagi tentang umku nggak, Kak?
Tentu dong, yuk kita lihat-lihat ke dalam.
Umku memiliki 3 fakultas dengan 20 program studi, yaitu Fakultas Ilmu Kesehatan, S1 Keperawatan, S1 Farmasi, D3 Keperawatan, D3 Kebidanan, Profesi Nurse, Profesi Apoteker, S1 Kebidanan, Profesi Kebidanan, S1 Administrasi Rumah Sakit, D4 Teknik Laboratorium Medis, dan S1 Gizi.
Ada juga Fakultas Sains dan Teknologi loh, yang terdiri dari S1 Matematika, S1 Ilmu Komputer, S1 Sistem Informasi, dan S1 Teknik Industri. Yang terakhir, ada Fakultas Ekonomi, Pendidikan, dan Hukum, yang terdiri dari Prodi S1 Ekonomi Syariah, S1 PGSD, S1 Akuntansi, S1 Hukum, dan S1 Bisnis Digital. Bagi kalian yang belum tahu bagaimana laboratorium penunjang untuk praktikum di setiap prodi, di umku memiliki laboratorium farmasi, keperawatan, kebidanan, komputer, bahasa, dan lainnya. Kita sekarang berada di ruang serbaguna umku yang digunakan sebagai ruang pertemuan. Di sini memiliki fasilitas videotron, pengeras suara, dan ruangan yang ber-AC.
Universitas Muhammadiyah Kudus mendapatkan akreditasi dari Badan Akreditasi Nasional Perguruan Tinggi dengan predikat B.
mempersiapkan masa depan kita, umku menjalin kerjasama baik di dalam maupun di luar negeri. Beberapa di antaranya, University Kebangsaan Malaysia, University Kuala Lumpur, Mahsa University, Dongseol University Korea, Wusuk University Korea, College of Pharmacy Taipei Medical University, College of Nursing Taipei Medical University, National Taipei Medical University of Nursing and Health Science, dan masih banyak lagi.
Universitas Muhammadiyah Kudus berkomitmen mewujudkan lulusan yang berakhlakul kalimah Islam, berwawasan global, dan memiliki kemandirian dalam berwirausaha. Umku Self-Oriented Islamic University. Mari bergabung bersama kami di 20 program studi di Universitas Muhammadiyah Kudus.
Prestasi mahasiswa Umku cek.
Kami di bagian kemahasiswaan siap mensupport prestasi mahasiswa dan kegiatan kemahasiswaan di Universitas Muhammadiyah Kudus.
Kak, selain bisa mengikuti perkuliahan, di sini kita bisa berkegiatan apa lagi nih?
Bisa dong, di umku kalian bisa berkegiatan dalam organisasi mahasiswa, yaitu di BEM dan IMM, serta unit kegiatan mahasiswa atau UKM lainnya. Di minat olahraga contohnya, ada tapak suci putra Muhammadiyah dan bulu tangkis.
Dan untuk minat kesenian, ada teater, tari, serta paduan suara. Untuk minat khusus, ada KSR, Korps Sukarela, PMI, dan Kepanduan Hizbul Waton.
Oh iya guys, umku sekarang telah mempersiapkan gedung baru yang modern loh, tentunya dengan fasilitas-fasilitas yang lengkap.
Untuk menjawab tantangan zaman, Universitas Muhammadiyah Kudus senantiasa meningkatkan pelayanan kepada masyarakat dan publik. Salah satu upaya adalah dengan menambahkan sarana dan prasarana yang ada. Convention Hall, Kampus 2, dan Gedung 13 lantai untuk mendukung dan mewujudkan visi misi Universitas Muhammadiyah Kudus, Global Entrepreneur Islam. Join with us.
Bismillah, kami merajut masa depan yang terbaik. Universitas Muhammadiyah Kudus.
Ladies and gentlemen, it's now time for a photo session.
Well, ladies and gentlemen, I invite the Rector and Vice Rector of the University to join the photo session together. So we'd like you to come to the stage. And to all speakers, Professor JIN-RU and Dr. JEYA, also joining us. Now we are ready for the photo session together. Okay. One, two, three. Again, one, two, three. Okay. Right. Now using thumb, please. Professor Jean and also Dr. Tia show the thumb in a photo session. One, two, three. One, two, three. And now I invite a speaker to join the photo session together to Mr. Sukarmin and also Mrs. Anny Rosiana Masithoh. One. Okay. One, two, three. Again, one, two, three. Okay, so maybe we open mouth for a while. One, okay. One, two, three. Again. One, two, three. Okay, and for the last freestyle. Okay. Freestyle. All right. One, two, three. Again, one, two, three. Thank you very much.
Ladies and gentlemen, those are the opening of 4th International Webinar Series on Nursing at University of Muhammadiyah, Kudus. That's all from me as Master of Ceremony. Let's close with saying Alhamdulillah. Alhamdulillahirabbil alamin. Billahi fi sabilil haq fastabiqul khairat. Assalamualaikum warahmatullahi wabarakatuh. Now we come to the main agenda of 4th International Webinar Series on Nursing at University of Muhammadiyah, Kudus, entitled Elderly Nursing Care. This will be guided by Mr. Ahmad Nur Shafiq, Master of Education, as moderator. The floor is yours.
Thank you, Mr. Master of Ceremony. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Innal hamdalillah nahmaduhu wa nasta'inuhu wa nastaghfiruh wa na'udzu billahi min shururi anfusina wa min sayyiati a'malina. May yahdihillahu fala mudhillalah wa may yudlil fala hadiyalah. Asyhadu an la ilaha illallah wahdahu la syarikalah wa asyhadu anna Muhammadan abduhu wa rasuluhu la nabiyya wa la rasula ba'da amma ba'd. First of all, let's pray to our Lord Allah subhanahu wa ta'ala for his mercies and blessings. And also our deep gratitude please be upon to our Prophet Muhammad sallallahu alaihi wasallam. Well, ladies and gentlemen, welcome to join in a 4th International Webinar Series on Nursing today. In today's webinar, we are going to talk about elderly nursing care. Well, ladies and gentlemen, as all we know, each of 201 countries or area with at least 900,000 inhabitants in 2017 is projected to see an increase in the proportion of persons aged 60 and over between 2017 and 2050. While in our country, Indonesia has the fifth largest elderly population in the world, and in 2012 there are nearly 21 million elderly people. And every single country has on way to care elderly in every single country. And it is becoming a very, very interesting topic to discuss today. My name is Safik, and I'll be serving as the moderator for this webinar. And before we go further, so we would like to say thank you one more time to the convener of Taipei Hospital and Taiwan International Healthcare Training Center for collaboration and support for this webinar. And together we have 4 expert speakers who are going to talk about this topic in a very comprehensive and a very deep today. Right, to save our time now, to begin the first sessions, let me keep in touch with the first speaker, Professor JIN-RU from National Taipei University of Nursing and Health Science, Taipei, Taiwan. So, Professor. Hello, Professor.
Good morning. Hello,
okay.
everyone.
Right. Okay, so it seems that we are connecting with the Professor JIN-RU, and she will begin the presentation in the first session. Today, she will talk about psychiatric and mental health care for older adults in Taiwan. But before she delivers the wonderful presentation, I'd like to read her curriculum vitae first. Her full name is JIN-RU. Now he is a professor of School of Nursing of National Taipei University of Nursing Health Science, Taipei, Taiwan. About the academic qualification in 1991 to 1993, so she works in a National Taiwan University School of Nursing. Meanwhile, in 1997 to 2000, she works in A.Kep Western Reserve University, France, Spain, Bolton Schools of Nursing. And about the professional qualifications, she begins her career in 2006 as an advanced psychiatric registered nurse in Taiwan, and in 2009, community mental health nursing specialist of Taiwan, and 2016, so as a chairperson of the academic committee of Psychiatric Mental Health Nurse Association, Republic of China. About the research interest, so the research interest focuses on psychological and mental health nurses and role and competencies development, psychiatric and mental health care of a chronic psychosis and older adult. And she was convener and the principal of investigator of the mental health research group in Taiwan since 2000. Many of her research studies involve interdisciplinary collaborations. That was really, really amazing. And these studies are designed in a partnership with the clinical practitioners, clients, and families, and faculties of nursing schools whenever appropriate. There are also collaborative projects with the national and international partner. So that was a really, really amazing curriculum vitae. Okay, to save our time, now we will go directly to the first sessions delivered by Professor JIN-RU. So, Professor, now the floor is yours.
Okay.
So, Professor, before we go to the presentation, we'd like to invite you once again for the photo session together. Right? Yeah. So, we will have a kind of a photo session together before the presentation. So, I invite Okay, so I invite the rector and the vice rector to join to the stage to have a photo session together one more time with the Professor JIN-RU, PhD.
都是他等下会 cue， 然后他们现场是这样，对，然后你就看前面那个镜头，对对对。就是第一张是就是一般的这样子，你也可以稍微微笑都可以。
Okay, so 1, 2, 3. Okay, 1, 2, 3. Okay, so maybe using Tom, Professor, Jim, maybe. All right, thank you. Okay, now 1, 2, 3. 1, 2, 3. And now with the certificate, if a professor is available for the certificate, you may take to go with you for the photo session together. Okay. Right then. 1, 2, 3. 1, 2, 3. Okay. Right. Thank you very much, Rector and the Vice Rector. Right. Okay, and now we will go directly for the first session, the presentation delivered by Professor JIN-RU, RONG, PhD. The floor is yours now, Professor.
Thank you. 好，分享。你要选荧幕。Okay. Hello, good morning, everyone. Yeah, today I would like to present about the mental health of old adults, particularly in Taiwan's experience. I am Rong Jin-Ru, and I'm teaching at National Taipei University of Nursing and Health Science. And I'm a teacher at School of Nursing. My research focuses on psychosocial and mental health intervention. Many of my study involve aging health and care. Particularly, I was working in and with elderly people and healthcare professionals. And this is my email address. If you have any question or any at School of Nursing interchange with me, please can email to me. Today, actually, I have two parts want to sharing with you. The first part is I will talk about the general information related to elderly mental health. And the second part is I want to explore about the two issues. First is explore psychiatry, mental health care in needs of elderly people. Second is the discussion about how to develop a psychiatry nursing role in elderly mental health care and the experience of I working in Taiwan. So in this part, you can see actually mental health problems have performed harmful health and psychosocial consequences. The major fourth mental disorder in elderly, I will mention that, and we were discussing about the consequences of this mental illness. First is depression. Second is cognitive impairment. Third is suicide. The fourth is chronic psychosis, such as schizophrenia. And the consequence will cause about functional decline, increase the risk of dementia, and make the people feel poor of quality of life. Particularly, they may die earlier than other old adults. So the key information related to elderly mental illness. First, we need to know mental health and common mental disorder are largely affected by the individual factors, societal factors, economic and environment of life. And in society, the stigma and the negative attitude toward mental problems will affect the recovery outcome of mental illness patients. So we need to take action to improve the negative attitude and building a friendly living environment for our elderly people or our elderly mental illness patients, promote their health and reduce mental disability. But first, we need to enhance carries knowledge of elderly mental illness, because if we have knowledge, we can promote professional and non-professional care actions. We can build a friendly environment for the elders. And we need to use evidence-based scientific information to provide mental health care for our elderly psychiatry patients. Before we talk about the disorder or disease in elderly patients, we need to discuss about the risk factors for mental health problems among older adults. Actually, the elderly people, they may experience life stress, and this life stressor will cause about isolation, loneliness, psychiatric distress in elderly people. Mental health has an impact on physical health and vice versa. So it's interaction between mental health and physical health. Elderly people with physical health condition, they will have high rate of mental health problems such as depression. However, the depression or elderly psychiatric problem were under-treated or under-estimated or under-assessment. Such as like depression, under-treated depression in an older person with chronic disease can negatively affect its outcome, including physical and psychological outcome. So the mental illness problem of Taiwan, I will introduce the Taiwan society is an aging society. The average lifespan of elders is 81 years old, and one elders in every 5 persons. The prevalence of mental illness in the elders is serious in Taiwan, particularly in dementia problem. Most elderly people will seek medical treatment for their physical disease. However, they rarely seek mental health treatment or mental health care assistance. The mental illness of elderly people is often untreated due to misunderstanding, including cognitive impairment, depression, and other mental illness conditions. First, I would like to introduce about the depression. Depression can cause great suffering and lead to impairment function in daily life. In the all of the world, unipolar depression occurs in 7% to 15% of the general population. And depression is both underdiagnosed and under-treated in primary care setting. So this is a CT scan picture of the brain. In the left side, this is a brain active of depression period. In the right side is a brain active with normal health brain activity. So you can see that in the brain of depressed period, you will see there has green and blue colors. It means the brain activity decrease. However, in the right side, there have yellow and blue and yellow and green. That means the brain activity is very active. So depression means depression disorder or depressive disorder is actually a brain disease, not only is a psychological or sociological problem. Second, I would introduce about the dementia. Dementia is a syndrome in which there is distortion, memory, thinking, behavior, and the ability to perform everyday activity. All over the world, there are almost 50 million people. And in the lower or medium income country, actually nearly 60% elderly people have dementia. So the totally dementia patient or dementia people in 2030, it's estimated 82 million. And in 2050, they estimate 152 million. And this is a physical, emotional, economic pressure can cause stress to family, to carers, not only for the patients. So if we look about the brain picture, so in the left side is a healthy brain. However, in the right side, this is a brain of Alzheimer's patients. So we can see in the Alzheimer's patients, the brain structure change, like atrophy, and they have many different structures. So dementia is a brain disease too. And during the dementia, they probably were from the mild stage to severe stage. And this duration around 7 to 10 years. In mild stage, probably will last 2 to 4 years. And the elderly may have memory loss, personality change, and diminished judgment. In the moderate stage, this will last 2 to 10 years. And at this stage, the patient will have behavior, personality change, and they may have some psychiatric symptoms like wandering, agitation, aggression, and confusing. Of course, in this stage, they require assistance with activity, daily living. In the last stage, severe stage, it probably will last 1 to 3 years. In this stage, most of elderly cannot have activity or working. Most of them are bedridden and unable to perform daily activity, and most of them need help and will placement in long-term care facility. And this is a progressive dementia, and if we measure by the score of mental minimal status examination, the MMSE, the score probably from 28 or 27, we're approaching to 0. In the early diagnosis, probably the cognitive symptom, we will see they will decline. And in the middle to moderate stage, the MMSE score will decrease under 20. And in this stage, they will lose activity, daily living skills. They have many behavior problems. They may need nursing home placement, or they will early death than other elderly population. And they will need caregiver to provide cares. So in Taiwan, dementia patient, we need to understand how about their living situation. So in Taiwan, in the elderly population, the prevalence rate of mild dementia nearly approaching to 5%. That means in every 20 elderly people have one person suffering from dementia. And who cares of these dementia people? Actually, 96% of these dementia patients living with their family, and it depends on their family caregiver to provide care. Only 4% can enter to nursing home, and probably 3 to 4% will care by the home care. or daycare center from the government service. And third is the aging of schizophrenia patient, because in psychiatry, the majority patient, we will mention about schizophrenia. But schizophrenia patients, they will getting older. So we would like to explore the aging of schizophrenia, what will happen. In the first is the psychiatry symptom, like positive symptoms will reduce. However, the negative symptoms will increase. And their health problem, not only in psychiatry symptoms, but also will affect their like the general health condition. So the health problem will emerge a lot, like the oral hygiene, constipation, or sleep problems. And this is continually about the aging process of schizophrenia patient. Moreover, they will have complex chronic comorbidities disease. And this probably like DM and cardiovascular disease. And because the aging and schizophrenia process, the patient will change to more poor self-care. They will decrease self-care ability. So in aging of schizophrenia patient, we need to know about a few issues. First is the lifespan shorter than general population. The average lifespan of person with schizophrenia is 15 to 20 years shorter than that of an unaffected person, because they have higher morbidity and mortality rate. Patients with schizophrenia have 2 to 12 times higher mortality rate than age-comparable general population. So that is mean many review or study exam that is accelerate aging in schizophrenia. So schizophrenia is not only a brain disease, but rather a disease of the whole body. So we can see from the depression, dementia, and the aging of schizophrenia, we can understand there have multiple factors will impact of aging on mental illness. First is gene expression and regulation. Second is they may have many chronic illness. Third is the brain tissue will change, like atrophy or change the structure. Fourth is they will cause neurological decline, neurological functional decline. Fifth is because they may need to control the chronic illness and the mental illness, so they take many medication, and this medication will have interactions effects to impact to elderly people, cause about metabolic health problem like DM, and they will cause the protein synthesis slow down and the inflammation, and the cell have toxic. And they may have a vascular problem like chronic, like cardiovascular disease. All of this will decline in living ability and cause them social isolation. And all of these are a stressor to impact to our elderly people. So in this part, what care needs and the service need by our elderly mental illness patients, and what challenge will need be solution. And this has three major care needs we need to think in. First is their health promotion and disease prevention. Second is they need to care about chronic psychosis process. And third is elderly people actually living in community. So whether they can access community-based care service. And fourth is we need to provide like integrate healthcare service for our elderly people, and need to support their family caregivers. And we need to consider how to developing long-term care facility or resource to provide our elderly people. All of this will cause challenge to our nursing professional, and our nursing professional need to explore the needs of our caregiver and to develop effective care models providing care for our elderly patients. So the first, we may want to mention about the physical and the mental health promotion. What we need to do first is we need to provide a supportive environment for health care. And we need to providing mental social welfare, because the government can provide a significant important resource, and we can providing to elderly caregiver and elderly patients. We can use the family family network to provide care for our elderly patients. And that is mean we need to consider building an age-friendly environment. This age-friendly environment, that first we need to emphasize in change the society stigma and a negative attitude toward to elderly people or elderly psychosis patients. The long-term care offers a helping hand to disabled elderly. My philosophy in caring our elderly people is because elderly people, they still have many health problems. However, if we can help them solution their health problem, they may maintain their functioning and decrease the disabled condition, so they can live in the community, living with their family, and prolong the happy life. So living a long and happy life is need about maintain their functioning, or we need to provide long-term care in community. The third is suicide prevention. Actually, in Taiwan, the suicide rate in elderly people is higher than other age population. So, and the suicide in elderly people, they have one particularly characteristic is mean they have strong attention to die. So the suicide prevention, we set a Suicide Prevention Act, and this act was announced on 2019. And we set a hotline 1925. It can provide 24 hours free mental counseling service. And moreover, we hope the friends or neighborhood or family can understand the suicide sign and the syndrome among elderly patients or elderly people. In Taiwan, the Psychiatry Health Service, the government, Administration of Health and Welfare, they continually to utilize around 7 general psychiatric care networks in Taiwan. And within this network, design core hospital, promote mental health within the region, and develop the region psychiatric care network. Taiwan is a small island. Actually, we only have 230 million people in Taiwan. So actually, around 1,000 people, we have 9 psychiatric beds. And we have around 68 daytime psychiatry rehabilitation institutions and 150 for psychiatry rehabilitation institution, psychiatry daycare center, and psychiatry nursing home. Moreover, we provide one community outreach care service. And this, because most of our patients or people living in the community, so we hope they are not stay in hospital too long. So we hope that they can go back to the community living, and we providing outreach community care. And this outreach community care can use the home visit and the telephone visit. And in 2019, we announced Long-Term Care Service Act. So we can provide in community long-term care service or provide long-term care institution care. And more, we asked about care management system, develop diverse innovation service. Like in the community, we have 3 levels of community service. First, A level is providing community integrated service center. And level B is combined service center. And level C is more like long-term care station around the blocks. So different patients or different elderly people can, based on their functioning, to access this different service. So need to construct the integrated community care service network. We development and the developing of service resources such as home care, daycare, family care, and we provide assistant instrument, nutrition food delivery service, and transportation service. And we provide home nursing care, home-based, community-based rehabilitation, and other professional service. Okay, so according to above that I introduced is more like a general information. Then we will thinking about the challenge of the care issue for elderly people or elderly patient. So for the nursing professional or for other healthcare professional, how to develop the mental health care for the elderly is needed to conduct with several questions. So this 4th question that need to be thinking about first. What are the themes in the geopsychiatry nursing model that are provide care for elderly patients? Of course, we need to provide the elderly patients' needs. So we need to thinking about what are the elderly mental illness patient needs. And the third is how to implement an integrated care model for elderly patients with mental illness. And fourth is what are the geopsychiatry care for elderly people or mental illness patients. So because I want to answer this question, I do a lot of serious study. And there have 6 publications that come from my study, and I put here, can provide you a resource that you can, if you can have a chance, you can read this information from this publication. And all of this study is working with my partnership. My study partner, including researchers and the practitioner and the elderly patients and their family. So first, I want to explore the nursing need and explore the essential competency of geopsychiatry nursing for elderly person with mental illness. Now I want to introduce my study This study is actually a serious study. I separated them as a two stage. In the first stage is to explore the care needs of elderly patients. And first, I focus on depressive patient and schizophrenia patient to develop the integrated care model and to develop the nursing competency. And second stage was to apply the integrated care model for elderly, depressive, and schizophrenia patients who live in community. So in the first stage, I using the qualitative study to interview with depressive disorder and schizophrenia patients. I using a group, focus group to interview with them. And I find that in depressive patients, even they suffering from depression emotion or suffering from aging problem, but they still show the strength to coping with aging and the mental health problem. Three main themes I find that. First is bear the bitterness of life. Second, they can adherence to psychiatry treatment and the use of resource to coping with life stress. Third is they still maintain the willpower to survive, control disease and health problem motivated. So this is a concept framework. They still strength to survive for coping with aging and the mental health problem. They can show the three major activity in this part. Second, I interview with elderly schizophrenia patients using the focus group, and I interview with them and I do the qualitative analysis. And I find that they are still struggling with aging and illness. Have five major things. First is the schizophrenia elderly patient living alone, feeling lonely, and they have to caring for themselves. Most of them feel anxiety and pessimism about the future. And also they feel internal conflict about the disease and aging process. However, they can seeking help and they learn about how to delay the needs and engaging in health activity. These five major themes show the elderly schizophrenia struggling with aging and illness. Then they can live in the community. From the two parts, I can integrate about the care needs of elderly psychiatric patients. First is they need about physical and mental health care and support, and they need to access to medical and psychosocial resource. Of course, they need to be value and awareness of personal existence and the willpower to survive, and they need to management common old adult syndrome and mental health problem. Most part of them mention about they need to arrange for living and long-term care facility, and they need to maintain contact with family in the community. So this is the needs of our elderly patients, and what are the service in integrated care model, and what the nursing competence need be built. So I using the literature review, and I using the experts, professional experts discussion group, and do a survey. I find that actually they have 5 dimensions in integrated care model, and building, we can based on this 5 dimensions to building nursing competency. First is we need to do the health assessment and provide disease care. Second is we need to provision of spiritual security care. Third is we need to help them maintain of life mobility. And we need to provision of resource link. Of course, in this care process, we need to emphasize nursing care ethic. And in my study, I do these 5 integrated care, and I'm using individual home visiting or telephone visiting to my clients. So first, I do this integrated care model for elderly community dwelling patients. Totally, I have 2 groups. One is comparison group and the other is experimental group. They all be diagnosed depressive disorder, and they all living in community. And I provide integrated care by expert psychiatry nursing. They go to the community, go using home visit and using home care to approaching our elderly patients. And then I using qualitative and quantitative structure instrument to collecting the response of our patients. So this study actually I do about 18 weeks, and I collect I have three time data collecting in the beginning, 12 weeks and 18 weeks. And I saw that of course, the psychiatry nurse need to be trained, and the psychiatry nurse, after the training, the psychiatry nurse increase their knowledge and skill in providing elderly depression care in community. And the patients, they have change at mental health status, and they change about the depressive emotion. And from this part, you can see that this first is their emotional score, and this is suicide ideational score, and this is a depression score. The green line is experimental group. The blue line is comparison group. You can see the experimental group decrease their symptoms, psychiatric symptoms, and decrease the suicide ideation, and decrease the depression emotional level. So that means the integrated care model, and through a home visit or telephone visiting, can result as change and improve the quality of care and improve the condition of our elderly depression patients. And second study, I using a problem-solving skill training for our middle age and older age schizophrenia outpatients. And this PSST is mean problem-solving skill training. This intervention, I do this in community, and I hope that it can help our elderly patients have more effective problem-solving strategy, can handling their condition and improve living skill. And this PSST, the major parts I do first in appraisal and accepting one's problem experience. And the elderly subjects can selecting problematic or stressful life experience and practical to change the problem. So they go through these 3 processes. Of course, I using some cognitive restriction strategy, problem analysis strategy, and increase awareness of their internal stimulus and behavior, help them practicing self-control exercise. All of these participants in this study were on a stable antipsychotic medication and through 16-week study period. And these effects can show that there have positive impact on the negative symptom of schizophrenia patient and could improve their problem-solving capacity and skill for dealing with daily life and health problem, and they can control about negative psychotic symptoms. This is like a result of this study. I only provide one result is self-control skill. This green line is experimental group. This blue line is comparison group. So you can see there has a interactive effects, and the experimental group, they increase about self-control skill. That means they increase the problem-solving skill. And the third is I do another intervention to providing elderly schizophrenia. I call them health living program for our elderly schizophrenia. And this health living program, actually they using the health control behavior concept. And I hope that they can change their health behavior and change their psychotic symptoms. And this participant are still stable, take antipsychotic medication about 16 weeks study period. So this healthy living program still focus on about how to self-management their health problem. And this self-management problem, we can see this is the outcome. This health living program, promotion program. This part is self-control behavior, and this is health life attitude. So the black line is experimental group, and this is a comparison group. So we still can see from the 16 weeks, the experimental group can increase their self-control behavior. And in the health attitude, the experimental group still can increase and higher than the comparison group. So after this 3 study, we can understand the nursing in geopsychiatry need to do these 5 important nursing care. First is health assessment and disease control that I mentioned before. And 2, still focus on spiritual security care. 3rd is help this elderly maintain life mobility and energy. 4 is help them link to health and social well resource. And the healthcare need to apply ethics and the principles to care our elderly patients. So the future, what we were thinking about the geopsychiatric nursing, what we need to development. So in this part, I want to mention, if we want to promote geopsychiatric nursing, that we need to depend on cooperation among the healthcare industry. Not only the nursing field, we need to cooperation with other professional field, cooperation with our patient and their family. And this can be promoted by the education, because most of our nurses or nursing students in our nursing lecture, we didn't mention about the elderly psychiatric care. And we need to put this part in our education, no matter in the school or in service education, help our nurses to know how to approach into elderly patients or elderly psychosis patient. And we need to tell them how to providing care, how to communication with our patients. Then the professional staff can help their family and help family to know how to care their elderly relatives in community. So the future development in mental health, elderly mental health, we need to consider about the future needs because society still continually change. So the patient's needs or people's needs will change. So for the future, we need to continually to explore the needs of our elderly people. And in different region, different community or different country, we have different issues need to be explored. Second is we need to going with or participant about health policy. We need to participant how to building more friendly health policy and resource. Third is we need to promote empirical research. Empirical research information providing about practical nursing and providing policy formulation and can input our professional education. Four is actually we need to development about management and operational risk care strategy and the development community-based model for our elderly people. So the future challenge may still have these four parts. We need to alliance of health professional and the social resource. We should consider how to impact health policy and empower health care on elderly population. Third is developing psychiatric care for our elderly illness patients and transform this and innovated this information to students, to professionals, to community, cooperational peer. So mental health is an important part of human health and well-being. And personal mental health or mental disorder are affected by personal condition, psychological, social, economic, and environment factors. So the one important concept like empowerment and social self-control and self-management, like this concept is very popular in our country and also in other countries to provide our elderly individual and their community have the ability to control the mental health problem and can enhance their ability and decrease mental disability. So in order to incident of mental disorder caused by many factors, so we need to using a different resource, helping our elderly people and helping their family to providing an healthy life and decrease their disability. So finally, this is end of my presentation. We need to consider care and cooperate with old elderly people and their family. Thank you for your attention, and maybe we can have some question can be discussing and interchange our opinion in the last part of this presentation. Okay.
Right, so that's the wonderful presentation from Professor JIN-RU. Okay, so I believe all of you participants of this webinar are really interested in that topic, and maybe would like to ask some questions to Professor Jin. Now I'd like to open the question and answer session or discussion. So to the webinar participant, so you may raise your hand virtually or even writing in our chat room to ask a question. Both of them are acceptable. Now, please, I will invite all of you to join in a session of question and answer.
Yeah, please. You can ask any question.
Yeah, of course. So is there any questions?
OK，
对，字幕。然后有些是现场观众提的。
The webinar participant, you might raise your hand virtually to ask directly to Professor Jin, or even you can write your questions in our chat room.
Probably this is a not common experience in different countries because in Taiwan the aging population is large than it's increased very fast. So we have many many healthcare issues for our elderly people. But in your country, probably you are still young. And probably you don't have, and I think the lifespans in different countries probably is quite different. Like Taiwan, the average lifespan is 81 years old, but in different countries probably you have different age. Yeah. So that means a lot of healthcare professional or nursing professional, we don't have many experience in approaching with our elderly people.
Okay. Yes, Professor. So maybe in every single country has a different way to care the elderly, of course. And yeah, maybe I think the presentations are really, really good. Yeah. And now we understand in Taiwan has own way to care the elderly itself. And maybe we have one question. Yes, for the participants.
Okay.
Okay, so one of the participants, Anwari, raised hand. So Mr. Anwari is raising hand, means he would like to ask directly to Professor. Okay, so
yeah.
Right.
Please.
The floor is yours.
Okay. Good morning, Prof. Hello.
Hello, I heard you.
Okay, can you hear my voice?
Can see you, but I heard your voice.
Okay, I address you from Indonesia. When I see your explanation about this webinar, this is a great. I listen that. Today I would like to ask the questions because I focus to elderly. When I'm talking about this elderly, in the community.
Excuse me, could you repeat again? Could you repeat your question again?
Okay. When I'm talking elderly, so this generally accepted that elderly people, because of some conditions, require more intensive management that can be provided in the community. The admission of elderly patients to hospital, their treatment and subsequent discharge can prove challenging with self-sufficiency depend loss of the underlying conditions. Delivering a package of care to an acceptable standard can make the difference between an individual who is a self-sufficient functioning member of the community and the old person who is this for you. Do the elderly need a special ward in hospital as the children have for a better care? Thank you.
Okay. So, right. If I can get the question, Professor. So, Mr. Anwar is asking about, do we in our hospital, for example, need a special care to care the elderly in the hospital? So maybe that's the question, Professor.
Okay.
Yeah.
Actually, I separated this condition as two parts. One is for medical, surgical, nursing care. Actually, in Taiwan, the hospital, most of the patients live in or treated in hospital, they are older people. Because in the psychiatric parts, the elderly or geopsychiatric medicine is like still like a new area, Although we have the geopsychiatry ward in psychiatry hospital, and this geopsychiatry is mean elderly patient living in the hospital, and in the community. Actually, majority of elderly people, they will living in hospital and go back to the community. And however, the community nursing care resource that is still need to be expanded. And the nurses or healthcare professional, most of them are familiar with about the elderly patients who live in the hospital. They are not have so many experience to understand about elderly patients in community. So we have Taiwan Psychiatry Nursing Associations, and we are promoting this part of competency to help our nursing staff to understand the challenge or the needs of our elderly patients. And we provide like the seminar and the workshop to help our nurses to understand how to working with their elderly patients. And moreover, we set like a certification procedure for our nurses to if they can pathway or they can get the training, we will give a certificate with them, and that they can have the qualified to provide healthcare in community. Is that you want to understand? Is that this information is your question? Yeah. But I still want to mention, because Taiwan, we have like healthcare insurance system, and we actually the reimbursement, the healthcare reimbursement, most of them focus on reimburse to hospital service. They not provide a lot of healthcare resource to community. That is, we need to emphasize or need to participating about health policy formulation. So even the nurses or other health professional, we are very aggressive to participate about health policy formulation, particularly how to provide the health resource to our community elderly people.
Okay, so that's the detailed explanation from Professor JIN-RU wrong. So, Mr. Anwari, hopefully it is really answering your questions very well. And we are moving now to the next question, Professor. So the question coming from Mr. Sukarmin addressed to you. The question is, what is the role of nursing professional organization related to the elderly mental health in Taiwan? So that's the question, Professor.
Okay, thank you. Because I was president of Taiwan Psychiatric Nursing Association. So if this, you mentioned this nursing professional organization, it means professionals association, that we set this competency as our in-service educational program. And we, like I said, we do the workshop and the seminar and to expand about our finding and our knowledge. And the other part is we have using the certification system in our Psychiatry Nursing Association. We use the certification. Like now we have 3 kinds of certification. One is Psychiatry Mental Health Nursing certification, and second is Community Mental Health Service certification. And third one is Clinical Specialist in Psychiatry certification. Of course, we have another one important system development like a Psychiatry Nursing Practitioners system. This 4 part is like we can help our nurses from RN and advanced RN and clinical specialists and special practitioners. So follow this 4 level, we can sending our information about not only about the elderly psychiatry information, but moreover about empirical evidence psychiatry nursing care information to our professional. And we hope that if our nurses can get more scientific information and get more workshop to practical their clinical skill, then we can provide more high quality care for our elderly patients.
Okay, so that's the amazing explanation from Professor Jin, and hopefully to Mr. Sukarmin who asked, it is really answering your questions. Okay, so do we still have any questions? Okay, we still have 1 or 2 minutes to finish the discussion. I think if you have any questions, you may raise your hand directly, or even you can write your question through our chat room. Okay, so we are moving now to the next question, Professor. So the question from Intan. Assalamualaikum warahmatullahi wabarakatuh. I want to ask about how to prevent Alzheimer's disease and what is the specific treatment for Alzheimer's disease? Thank you. So that's the question, Professor.
Okay. Actually, I want to know the answer about this question. Actually, it's hard to answer. And I think we need to get more evidence, research to find the answer, particularly for how to prevent Alzheimer's disease. I think the most of scientific research find that Alzheimer's is a brain disease, and the brain tissue change in our brain. The brain tissue change. So how to prevent, or how to, maybe we should say how to prevent disability of Alzheimer's disease. But we only can say we can, how to find and early estimate or early diagnosis whether this patient have Alzheimer or dementia condition. If they have Alzheimer or dementia condition, how to delay or how to maintain their functioning. But we may not can, now maybe we don't have medication, can treat or postpone the Alzheimer progressive process. So actually, that's why I say maybe we still need to going to find the answer now. But if the elderly people, they have good nutrition and good security environment, they can maintain their working ability and mobility a bit to move and to working with their colleagues or working with their family. They can get a lot of cognitive stimulus, cognitive dysfunctional stimulus, maybe can delay about the cognitive impairment condition. So if during my presentation there, from the beginning to the end, probably will maintain about 7 to 10 years in doing this Alzheimer progressive period. So if they can maintain their nutrition, can keep the safety, mobility, and working out with, communicate with other neighbors and give cognitive stimulus and cognitive activity, that will delay about this disease progressive and control about the mental disorder. So that's based my caring experience. I think actually most of the Alzheimer patients, they can, from they finding they have this symptom, they can keep about 10 years or more longer life to living with family in community. Yeah.
Okay, so
yeah, this is my finding. Mm-hmm.
Right. So that's the wonderful explanation. So maybe to prevent the Alzheimer, it's quite hard to explain because we need some more research. But I think, yeah, so the question is dealing with it, maybe how to give a special treatment when the elderly got the Alzheimer itself. And Mom, unfortunately, we are really running out of time, but we still have one last question. So I think the webinar participant raising hand, Mr. Duyan, if I'm not mistaken.
Okay. How to?
Or Vicky Rian Pranata, so now is raising hand. Okay, now, hello, Mr. Vicky. Yeah, so you would like to ask directly to the
hello, Mr.
professor? Yes. Hello.
Hello.
Yes. Okay, now go with your questions, please.
How to restore mental tone to schizophrenia patient?
Okay, so the question from Mr. Vicky is, show the question, please. Okay, how to restore mental down to the schizophrenia patients? So that's the question, Professor.
Okay, you mean the mental down is more, how to restore mental down is mean control the positive symptoms about schizophrenia patients, or control the mental disability of schizophrenia patients? Are you mentioning about if how to restore? It means how to help them maintain mental health functioning, how to maintain, because according to my research and my clinical practical caring experience, is actually schizophrenia. They are a brain disease. They will change their function, cognitive function. Particularly the cognitive function, one kind of cognitive function, we mentioned that executive functioning. Executive functioning is integrate about memory and self-control and communication skill and working or cognitive activity. So how to restore is give them like a recovery activity program or rehabilitation activity training to help them can using their brain, can can active their brain function. But most important is they have to take antipsychotic medication regularly. If they can take antipsychotic medication regularly, they can control the positive or agitation or aggressive or like hallucination or delusion symptoms. Then after that, if they can regularly take the antipsychotic medication, and they will, then we can help them to maintain the health functioning, cognitive functioning, providing the rehabilitation training or recovery activity training, and help them maintain the cognitive and psychiatric function. I think the most of psychiatric patients or schizophrenia patients, they may not regularly to take medication. Then this will negative impact to their function. So if we want to restore mental down of schizophrenia patient, first we need to working with them, help them regularly to take antipsychotic medication. Then we can help them get some rehabilitation training. Okay, this is my answer.
Right, so that's a very, very amazing presentation and discussion, Professor. But seems that we don't have any much time for this session. And yeah, hopefully to people who could not ask the questions, you may still asking questions through our email or maybe in our chat room. So we will pass the questions to the Professor JIN-RU wrong after that. And so, Professor, maybe I will end this session, but before that, I will ask you to please give your closing statement, Professor.
Okay, I show in my last PPT. I hope that we need to have this attitude, and we need have more knowledge to understanding our psychiatric patient and elderly people, because one day we will getting older, and we need our friends and our children providing a quality of care to us. So today, I think we need to understand about how to care our elderly patients or our elderly people. For the future, we will get feedback from our new generation. So that is, I think this is a very important issue, and we need to working together and continually to find the new information or new evidence. So working together and continually to development this issue is very important. Thank you.
You are most welcome, and thank you very much one more time to Professor JIN-RU. So please now give a virtual applause to Professor for the wonderful presentation. And yeah, finally, so I must end this session, Professor. I'll see you in the next presentation, Professor. Thank you very much. Goodbye, Professor.
Goodbye. Goodbye.
Right, well, ladies and gentlemen, so before we are moving to the next session, I'd like to inform that Taiwan International Healthcare Training Center, or what we call TIHTZ, is hosting 4 series webinars with University of Muhammadiyah Kudus in this year. And in the past 19 years, over 1,100 healthcare professionals from 72 countries have received a training through TIHTZ, including doctors, nurses, professors, healthcare administrators, health officer, and so forth. Now let's what is so special about their training.
Hello everyone, this is Dr. Harsh Jakheria from India. Last year I joined Taiwan International Healthcare Training Center's Dermatopathology Training Program. Wanna see how my life is like in Taiwan? Let's get going. This is our training lab. Let's go. Hello. Good morning. My clinical training consists of routine sign-outs, weekly review of typical and atypical cases on Wednesdays, clinico-pathological conferences on every Thursday, immunofluorescence and electron microscopy reporting, learning from archived slides and cases, and monthly self-assessment and topic tests. Dr. Wu is a great mentor and great teacher. If you have interest in dermatopathology, I would definitely recommend this program.
The level of medical service in Taiwan I think it's outstanding. It's very amazing. We also have many medical centers and provide advanced medical care. For the students or the scholars, we have a very good subspecialty training or specialty trainings. For the training of dermatopathology, this is a very subspecialty. Not many training centers can do this job. There is an international committee for dermatopathology. They will accredit the training center in the world. There's only 2 sites in Asia. The site in Taipei, our program, is the first accredited program for this ICDP. This is also a major site of Asian Society of Dermatopathology. And I'm the current president of ASD. And we will provide many teaching resources. So if you come to our programs, hope that can help in your future career. Those are from the same cells. It's lunchtime. Lunchtime. Good break.
I love Taiwanese food so much. Taiwan breakfast restaurants are pretty common and they would be open from early morning till afternoon. I got my choyo pain. Yay. TISTC is just like my family in Taiwan. We always have fun and celebrate all the special days together. We make rice dumplings during the Dragon Boat Festival. We twerk and dance at the year-end party. We celebrate the Christmas and open the gifts together. We have birthday parties every now and then. Everyone stay safe, stay happy and stay healthy. Thanks to TIHTC, I have experienced almost every aspect of the Taiwanese culture. I would really like to thank TIHTC for giving me such an indelible training experience. Not only do they have a wonderful dorm room, which makes me feel at home, but they also help me find the best hospital for my clinical training. Everything I've learned during my training would be conducive to the reinforcement of my profession.
Congratulations.
Thank you.
On your learning in Taiwan.
Thank you. Thanks a lot. I love Taiwan. I love TIHTC. Their first choice of clinical training platform.
Right now, we are moving to the second session. So in the second session, the presentation will be delivered by Dr. DEVI COOMASAMY from Education Consultant and President of Infusion Nurse Society, Malaysia. So before the presentation is done, let me keep in touch with her first. Hello, Dr. JEYA. Have you been connecting with us? Doctor? Doctor, hello.
Hi, good morning.
Okay, now, right. Very good today, Doctor. Okay, so before Doctor deliver the presentations, maybe I will invite all Rector and Vice Rector once again to join to the stage for a photo session together. So we will have a photo session one more time, Doctor.
All right. We are having a very busy morning, aren't we?
Yeah. Okay, so 1, 2, 3. Again, okay, so maybe we can open a mask. 1, 2, 3. 1, 2, 3. Now freestyle. Okay. 1, 2, 3. 1, 2, 3. Okay, thank you very much, Rector and Vice Rector. Right, Dr. JEYA today will talk about inserting a peripheral intravenous device in an elderly patient. But before she delivers the wonderful presentations, let me read her curriculum vitae first. Dr. DEVI COOMASAMY is a freelance education consultant and also co-supervisors PhD students at Mahsa University. She was formerly attached to the UCSI University as Associate Professor and Head of Nursing. Before joining the academy, she was attached to the Health Technology Unit of Medical Development Division, Ministry of Health, Malaysia. She had also served at Hospital UKM, Hospital M.Kep, and Hospital Kuala Lumpur in a various nursing position. Dr. JEYA graduated with a PhD education, Master of Science, Human Resource Development, and Bachelor in Nursing Science honors. She also has a post-basic certificate in orthopedic nursing, midwifery, and advanced certificate in nursing administration, a clinical fellow of Joanna Bridge Institute for Evidence-Based Practices, University of Adelaide, Australia. She has published articles in peer-reviewed journal with Liz in a Ministry of Health Malaysia, contributed to the publications of evidence-based clinical practice guideline and health technology assessment reviews. While in UCSI University, Dr. JEYA was a member of the Senate Teach and Learning Committee and several other committees. Dr. JEYA was a vice president Education Malaysian Nurse Association from 2009 till 2015 and is one of the founding members of the Persatuan Jururawat Infusi Malaysia. She is the first president of the society and is a strong advocate of best practice in infusion therapy management. Last, Dr. JEYA was awarded as the Ahli Mangku Negara or AMN in 2016, HRH King of Malaysia, oh my God. And in 2017, she received the Tokoh Jururawat Pendidikan for her contributions in nursing. In addition, she had also received Excellent Service Award from Ministry of Health Malaysia, Hospital UKM, and Hospital Kuala Lumpur. So that was a really, really amazing journey of life. Okay, so to save our time now, I will turn the time to Dr. JEYA. The floor is yours now, Doctor.
Thank you, Mr. Ahmad Noor Syafiq. Selamat pagi dan salam sejahtera dari Malaysia. Good morning, everyone.
Morning.
Saya ingin mengucapkan ribuan terima kasih kepada pihak kejururawatan Universiti Muhammadiyah Kudus kerana menjemput saya untuk memberi ceramah hari ini dalam talian pagi. Right. You had a very, very comprehensive discussion with Prof this morning, and for us in the Infusion Society globally, we consider the older adults as a very, very special patient population, and each of them have to be treated as an individual, and no one ages the same, and how they age is related to their lifestyle choices. Now, they may be old, but some of them can still be active, energetic, and independent, or they can be frail and highly dependent on the caregivers. So it all depends on each individual elderly. Many of the physical changes begins around the age of 60 to 65 years. We need to realize that 80% of these elderly patients, or elderly older adults, the warga emas, over the age of 65 had at least one chronic healthcare condition. Now, if they are admitted to the hospital, they may require infusion therapy for a variety of conditions or diagnostic purposes. Sometimes they may be discharged home and may still continue with their infusion therapy. So we have already moved into the community to set up infusions and nurse patients on infusion therapy. Now, having said that, and establishing and maintaining venous access for infusion therapy or intravenous medications can be extremely challenging in this population, especially now when the life expectancy has increased. People are living longer due to advances in medicine, improved nutrition, and self-care. Now, more and more, we are seeing the elderly in the age groups of 80s and 90s and even 100 years of age. Now, my presentation today will give a brief overview of the physiological changes in the aging body system and the impact of these changes on vascular access device insertion and care and infusion therapy management. I'm not going to give an anatomy lesson, but just a brief overview to link the why vascular access has to be careful when we are doing insertion and managing these patients. I will also share evidence-based practice recommendations to achieve best outcomes based on infusion therapy global practice standards. Now, if this is what an elderly person, a visual sign of aging, the aging process that we see found on the older person's skin, hair, and nail. The moment you see a person and you say, her hair is thinning, there's loss of hair, her hair is changing from black to white, the appearance of hyperpigmented areas on the skin, or the occurrence of fine lines and wrinkles, they are all visible signs of aging. However, there are many other changes that are gradually occurring in the integumentary system that have an impact on the insertion of a vascular device. Now, as individual ages, there is a decrease. We all know there's a decrease in fluid to body mass ratios. This is in addition to loss of collagen and elasticity, which makes the skin texture more pliable, lembut, soft. We must be extremely careful when inserting the IV catheter to prevent skin injury. With the loss of subcutaneous fat, the veins in the older adults have a tendency to roll. These rolling veins are quite difficult to stabilize when we want to insert a PIVC line, a peripheral catheter line. Now, as one gets older, the ability to perspire decreases and the skin becomes extremely dry due to the decrease in the number of sweat cells and the production of sebum. And this also causes problems for us. Now, we have the young skin and the aging skin. A person is quite loose and is basically hanging. Can you just imagine the skin of a 100-year-old? It's difficult to insert a PIVC through the skin without injuring the skin. Not only that, it's difficult to pull the skin and find the vein to insert the catheter. It's quite difficult to get into the vein. Now, in the skin, there are sensory nerves. Sensory changes that accompanies aging can cause a decrease in the thirst reflex mechanism, leading to dehydration in the older adult. When there is hydration imbalance, it makes the skin turgor. The evaluation prior to inserting a PIVC for infusion therapy becomes very difficult. Instead of the hand to do the evaluation, we have to resort to check or between the eyes. Now, the number of sensory nerve endings on the skin, let's look at the epidermis of the skin, yeah? I'm a little bit, okay. When the epidermis becomes extremely thin, it becomes inelastic with age. The collagen fibers decreases in number and the function resulting in the epidermis of the skin becomes very fragile, and this increases the risk for skin tears. And the skin of the elderly heals very slowly because of the skin cell turnover rate decreases, and there is less effective barrier against the introduction of microorganisms and bloodstream infections. So, as you all know that when we insert the PIVC, it has to go through the skin. So it has, we do not want to introduce any extraluminal microorganisms that are on the skin when we are inserting the catheter. Now, there's also a decrease in the number of capillaries, giving the skin a very translucent and almost a transparent appearance. The integrity of the capillary wall becomes altered as cells lose the water content. When the skin becomes less elastic and more rigid, it becomes fragile and increases the risk of bruising and vein rupture during venipuncture. So it is really saddening to see in our hospital wards a lot of our elderly patients having this kind of bruising. Yeah, I'm sure you all would have noticed that too. Now, sometimes we have patients who come in, the elderly patients, with thick and leathery skin. They have been working outdoors as laborers or working in the fields, and they have been exposed to the sun for very long. And when we are inserting the IV catheter, the skin, the thick skin, it sort of resists, and it will push when we insert, it will try to push the cannula out. Now, as we said, the elderly patients can have many conditions. Metabolic imbalances serve as comorbidities, and they may impact infusion therapy treatment as well. It can be due to the aging process itself or as a result of renal, hepatic, or endocrine conditions. Now, when there is decrease in water content due to the changes in function, it can be due to the changes in the function of the pituitary and thyroid gland. There'll be increased pruritus or dry skin. This pruritus or dry skin can also be due to adverse medication reaction. Now, again, when we are assessing the skin prior to inserting a cannula, a PIVC or a PICC line, we need to assess the skin. If we have this kind of skin, we cannot insert our catheter at this site. We have to look for a different area. Now, the management of the older patient's fragile skin during the AD insertion, we can use various methods to protect the skin. We have things like Cavilon in the market, which we use to apply before application of any securement, that is dressings, to secure the vascular device. And secondly, there is a correct method to remove tapes and hub securement devices. Unfortunately, many of our nurses are not aware how to remove dressings that are that are being used to secure the device. So they tend to pull it, and the skin of the patient comes along with it, with the the dressing. Now, we can also use adhesive removers or alcohol to loosen and remove any securement tape or device. But always keep in mind that you should not injure the patient. And this is what is happening now in the wards, in the clinical areas. We see a lot of patients with medical adhesive related skin injuries, what we refer to as MASI. And this is a concern for us in the Vascular Society, that the patient has already come in with a condition, and now the patient has got an additional condition that is caused by us, the healthcare professionals. Now, I'm introducing you to the Infusion Society. This is a global society with this. The HQ is in US. Now, the latest edition, the 2021 Infusion Therapy Standards of Practice, is something that we should have. And in there, Standard 55.1 actually states that VID sites, vascular access device sites, should be routinely assessed for signs and symptoms of skin injury. So that becomes our indicator for monitoring. And Standard 55.2 states that appropriate interventions are implemented to reduce the risk of and manage skin injury. So we are concerned of skin injury in our elderly patients. Now, the second system that is important to us is the venous system. Definitely, we are going to cannulate the patient. It has to go to the vein, right? As the patient ages, the veins in the body remains functional. However, the tunica intima and the tunica media, the layers of the skin, they become thick. The layers of the vein becomes thick and fibrous with aging, as you can see in the picture here. Yeah. The vein may appear to be very prominent in an elderly patient, but when you try to cannulate, it is very difficult. It's very rope-like. And even if the cannulation is successful, the infusion might not run correctly as we require. Now we have walls, right, in the vein, and these walls, as we age, becomes very rigid and sclerotic. There's increased resistance to advanced IV catheter in the vein lumen during cannulation. And these veins, the smaller veins, they are very fragile and they can easily rupture, especially when we apply tourniquet. Personally, I do not like to use a tourniquet in our elderly patients, right? I prefer no tourniquet and just using the arm in a dependent position, and we can see the vein distended for us to cannulate. So not necessary to use a tourniquet. And if you do use the tourniquet, and if you can't find the vein, do not leave the tourniquet too long on the patient's skin. We have to keep releasing the tourniquet, right? So it is not advisable. Now, our main purpose in giving any infusion, we need to increase the dwell time, yeah, of the IV device. Because in the elderly patients, most of the time we have not only difficulty in getting a venous access, but it comes off very easily. So it is better for us to insert the PIVC on the forearm rather than in areas of flexion, such as the back of the hand, wrist joint, or antecubital area. And also very comfortable for the older adult. You know, they don't fiddle with the IV infusion device when it is set in a proper place that is, otherwise it becomes like an irritant to them. No, so with the small fragile peripheral veins, our goal is to reduce trauma to the vein. So the ideal choice for older adults is either a 22 or a 24 gauge IV catheter. Now, the 22 gauge IV catheter is the smallest catheter, and the flow rate is between 28 to 37 mils per minute, and that's good enough. Now, today we have innovative catheter designs, which comes in 22G size, which can be used for infusing contrast medias instead of a large IV catheter. So try not to resort to large IV catheters because of it can cause trauma to the vein and the skin. Okay, definitely. In the elderly, not only in the elderly, but in sometimes in obese patients, we will have reduced number of prominent veins. And for the elderly, the vein distension takes longer because there is slow blood pooling due to low blood pressure, dehydration, and less vein elasticity. Well, in a younger adult, it may take 5 to 10 seconds, but in an elderly, it takes about 32 to 40 seconds for the vein to fill and to fill. So we have to be very patient, right? We try not to overstress the vein of the elderly. Slapping the vein is not going to achieve anything. Yeah, the vein can easily rupture and cause hematoma. What we can do is we can lightly tap the vein or apply digital pressure along the pathway of the vein to identify the vein. A very gentle tap. Yeah, because we do see nurses sometimes, healthcare professionals, not only nurses, but even doctors who keep on slapping the vein when they cannot see the vein. So that should not be the practice. Now, the insertion technique of cannulating the older adult vein, it should be at an angle of, the angle of 5 to 15 degrees is used. to avoid nicking or transecting the underside of the vein wall. For young adults, it's about 10 to 20 degrees, but in an elderly, only 5 to 15 degrees. Now, once the blood return is seen, the catheter should be lowered more to about 5 degrees before advancing into the vein lumen, about 1/8 to in catheter within the vein lumen. So it is a gentle process of insertion. Now, this is, we teach our young students from year 1 and all our nurses and all our doctors that only 2 attempts should be done when we are inserting a catheter. We don't allow multiple device, especially in older adults. And it has to be done by a skilled clinician. And this clinician has to be trained well and certified for doing PIVC. Can you imagine the pain that the elderly goes through? Yeah, they're already afraid that you're going to insert a device. Now, this is a standard actually in 34 practice recommendation G in our infusion practice standards. Now, whether the choice of the type of catheter, whether it's a peripheral intravenous catheter or a midline catheter or a PICC or other central venous SS devices, it depends on the treatment, even in the elderly. So it's not always PIVC. For example, if you're going to have a continuous vesicant therapy, it is advised that you use a PICC instead of a PIVC. Now, if you're going to give TPN or infuse it with an osmolarity more than 900 mils OSM, then we suggest use a PICC and definitely not a PIVC. Older adults have to be protected from complications such as infiltration, extravasation, just like any other patient of age, any age. But the older patients are very prone, yeah? Okay. Now, what we are advocating from the Infusion Nurses Society under Standard 2022.1 to use vascular visualization technology like like an infrared or an ultrasound to see the vein, so that we do not fiddle and unnecessarily we can't see the vein and then we try to find a vein and cause more injury to the vein. So there are devices now available, and we are recommending the usage of these technology, visualization technology. Now, the older adults, right, the immune system, right, the older adults, they are a greater risk for infection due to multiple medical problems and a weakened immune system. When signs and symptoms in these elderly patients, I'm sure you know, they are very subtle and atypical. So sometimes we don't even recognize it. So we have to be constantly alert for warning signs such as changing mental status, subnormal temperature, bradycardia or tachycardia, fatigue, lethargy, decreased appetite in the elderly patients. So these are some of the warning signs that you need to see whether they have getting a bloodstream infection due to the catheter. Now, all vascular devices, wherever you're inserting, whether it's a central line or a PICC line or an arterial line or a PIVC, they all are at risk for bloodstream infection. Now, our recommendations are, we use strict aseptic non-touch technique to all infusion-related procedures to prevent catheter-associated bloodstream infection, and that is standard 18.1. We try to avoid vigorous friction when doing skin preparation on the fragile skin of the older adult prior to an IV cannulation, so that we can prevent damage to tissues and causing the entry of the bacteria. We recommend the use of transparent dressings. There are many transparent dressings are available in the market for continuous visual inspection. And proper IV tubings and infusion system management to maintain sterility and integrity of the system, and try to avoid looping of the IV tubings in an adult patient, or contamination of the patient end of the tubing. Now, this occurs very often. Yeah? When you have the looping system, it sort of damages the skin of the patient, and that causes an extraluminal infection. The infection can go through the vein. There are lots of charts available on how to do assess VAD signs for signs and symptoms of infections or complications. Now, in Malaysia, we use the this chart by Andrew Jackson. Yeah. Okay. Now, with aging, there's a diminished hepatocellular functioning resulting in decreased liver mass and functioning. There's a risk of elevated drug levels in the blood, which increases the risk for drug toxicities and subsequent adverse effects. Now, when there's decreased blood flow to the liver, it alters the rate of drug metabolism. So we must be very careful when we are giving intravenous drugs. So assessment is very important, and we must consider the possibility of impaired drug metabolism. The elderly are prone to a lot of problems, isn't it? So one of them also is impaired oxygen exchange. Any change in this process can contribute to confusion and restlessness in the adults. Now, our concern is when initiating and continuing infusion therapy is with regards to safety of the adult patient. We have to protect the infusion site and the tubing with commercial securement devices. Don't tie the patient's hands, yeah, that is not allowed. There are securement devices in the market which we can use. Infusion therapy practices with regards to older adults should be clearly stated in organization policies. This is where here I would like to see policies and procedures in each organization available, and we should not, and in the policy there should be something that we shouldn't tie the hands of the elderly patient who's restless. I'm sure you all are aware of that. Now, this morning, Prof went through the psychiatric dementia and things like that. Neurological deficit in older adults can result in loss of cognitive functioning. Those with memory deficit may understand the reason for infusion therapy, and they can give us informed consent. But later, they may forget that they have a device, and they might try to pull it out. Yeah? Those with delirium may not even be able to follow instructions or directions. And again, they will try to remove the vascular access device and get out of bed, or and cause bleeding, bruising, and other injuries as well. Now, as we age, we get visually impaired, our hearing is impaired. Yeah? So when we are developing any infusion-related education materials, we should not make it general. For this older group, we need specific charts, bigger charts that they can see. And when we are doing education, we have to have eye contact. And we should not do any intravenous related procedures like giving of intravenous injection or setting an infusion therapy or inserting a cannula when the older adult is not aware of the activity. We must make sure that they are aware of the activity. We have to treat the older adult with dignity and respect. We have to wait, we have to be patient. It requires a lot of patience when we are dealing with elderly patients, especially in relation to vascular access devices. Now, the baseline physical changes that occur with aging have direct impact on IV fluid delivery. The size of kidney decreases with age, the number of glomeruli decreases, there's decrease in glomerular filtration rate, there's reduced blood flow to kidneys, and of course there's sclerosing and fibrosing in the glomeruli. This reduces the rate of delivery for IV. We have to be careful. We need to reduce the rate of delivery for IV fluids to prevent circulatory overload. Otherwise, you would have problems, yeah? For patients older than 70, a routine hydration rate should be no more than 8 to 10 mils per hour. We can't treat them as normal patients. Yeah, elderly, we have to have a different rate. So this is the rate that is recommended to prevent undue trauma. Then we do not want to give the unnecessary IV diuretics to the elderly patients, and we do not want them to stay long in the hospital. Any prolonged hospitalization will lead to more problems for the elderly. So in brief and in summary, older adults, we consider them a special population. And we have Infusion Therapy Society has actually come out with policies and procedures for infusion therapy of older adults. It is not the same as for adult patients. And these older adults have to be, they deserve to be treated well, and they deserve to receive evidence-based vascular device and infusion therapy management and care. So I would like to see policies and practice standards in every place in the clinical area. So with that, thank you. I've kept it brief. I know it's going to be lunchtime, so I didn't go into full detail, but giving you a brief overview of vascular care in the elderly. Thank you.
Okay, so now give a virtual applause to Dr. JEYA DEVI for the amazing presentation. Right, so yeah, I believe all of you had in your mind some questions to ask to Dr. JEYA after presentations. So now I will directly go to the discussion session or question and answer session. So like the previous sessions, you might ask a question through our chat room by writing your questions or even raising your hand, and then you can ask directly to Dr. JEYA. Both of them are available. So, okay, now I invite all the webinar participants to join the questions and answer session. Do you have a questions? Any questions?
No questions, time for lunch, is it?
Meanwhile, having lunch, so we can have still discussions, Doctor.
Yeah, I've kept it very general as possible. And I'm glad to share that Indonesia is joining our network as well, the Infusion Nurses Society network, and you all are in the process of forming the Infusion Nurses Society in Indonesia.
Okay. Yes, thank you very much, Doctor. I think so we have one participant raising hand. Yes, is that right? Mr. Anwari is raising hand. Or, okay, so we have a first questions coming from Mr. Sukarmin. The question is the use of INC cream effective enough to reduce the platelets? So that's the questions, Doctor.
INC stands for what?
INC. What is the INC stand for, Mr. Sukarmin?
Is it specific for vascular access device?
So it is a name, just a name of a cream. So we call INC cream. The name of the cream, sir. Maybe the name of the product.
Yeah, you must be careful when you're using any cream on the elderly patients. Yeah, not every cream. We want to have a little bit of sort of a.
Yeah, Doctor. So
lanolin in that cream so that it doesn't dry the skin. What is the purpose of this cream?
So go to your previous slide. You mentioned INC cream. So Mr. Sukarmin is asking about INC cream. Was it effective or not?
Oh, I didn't mention we are using Cavilon. Cavilon is what we are using now. For all of our patients, elderly patients, before we secure with the dressing, we spray it onto the patient's skin and then apply the dressing on top. Whether it's a PIVC dressing or a central line dressing or a PICC dressing, we are using Cavilon.
Oh.
So Cavilon has got a very, I do not know whether you use Cavilon, it has got a very thin protective layer. It acts like, so it protects the skin, very thin layer. So it's Cavilon.
Okay. Yes, okay.
But I'm sure there are other things in the market as well. Yeah.
Okay. Right. So that's the answer from Dr. JEYA. So to Mr. Sukarmin, hopefully it answered your questions. And now we are moving to the next questions from Mr. Anwari raising his hand. So I give the floor you to ask the questions directly to Dr. JEYA. Go with your question, sir.
Okay, thank you very much, Mr. Savik. Give me the time to make questions for Miss JEYA. Hello, Miss JEYA.
Yeah.
Good morning.
Hello. I didn't get that question. What is the question?
No. This is not my questions. I'm so glad to meet you, even though I find you in one of this camera, Miss JEYA. I'm talking elderly today.
Yes.
All elderly, elderly people age around 60 years old or more are susceptible to COVID-19 infections.
COVID, yes.
Yeah, because they naturally have experienced a decline in the immune system and organ functions, especially the elderly who suffer from chronic disease.
Yes, correct.
Such as hypertension and DM. And this is my questions. Are all elderly vulnerable to COVID-19, Ms. JEYA? Okay, this is my questions. Thank you.
Can you repeat the last line again? What is it that you said, Anwari?
Okay, my questions are all elderly vulnerable to COVID-19?
The elderly are the most of the patients in our hospital settings. I do not know in Indonesia as you are elderly patients, right? And most of them are admitted in the intensive care. I didn't get apa yang you katakan tadi. What was the last line that Anwari was? I didn't get that. What are you asking about COVID elderly patients?
By Indonesian or English? If Indonesian, apakah semua lansia rentan terinfeksi COVID-19? Are all elderly vulnerable to COVID-19?
Yeah, if you're talking about infection in the older elderly patients, yes. And especially now with the elderly patients, what we had, our experience, most of them were admitted in intensive care unit, and our infusion lines, we have a lot of, definitely catheter-associated bloodstream infection is very high, occlusion is very high, because the way, too many wires and so many drips for these patients. So there is a lot of complications, and those who are not admitted in the ward, just like any other patients, the elderly patients, we see a lot of infiltration outside because everybody wants to protect themselves, they don't go near the patients. So we had a lot of cases of phlebitis, infiltration of the infusion line. I do not know, but is that what you want me to answer? Is that what you're asking about the complications that the elderly faced as a result of the devices? Betul. Saya pun tak paham.
So maybe Mr. Anwar would like to emphasize things that why every single elderly is really in a big risk to have COVID-19.
Oh,
yes. Elderly age around 60.
They are. The immune system itself, right? It's very low.
Or more susceptible to COVID-19 infections. So that's my questions. Apakah semua lansia, are all elderly vulnerable to COVID-19? You know, this is for instance, they have lots of illness like diabetes mellitus and hypertension and blah blah blah.
Yeah, their comorbidities are very high, isn't it? I mean, they all have chronic medical conditions. Not one elderly is without a medical condition, and aggravated by the infection, COVID infection, it is worse in them. And frankly speaking, we are the ones who are spreading to our elderly. The elderly are quietly sitting at homes most of the time, right? It is the outsiders who come in and infect the elderly. That I'm not sure in Indonesia, but in Malaysia, we have now 2 clusters, which are elderly clusters, right? In the nursing homes. So definitely their immune system is low, and you can give them vaccination. The vaccination is not going to be helpful if there is no prevention. So we cannot nurse the elderly alone in the house, isn't it? We have family members. The family members can bring in the infection. So that is why they get infected. Yeah? So you're talking about COVID-19 is very difficult because the elderly are the highest number of elderly who are down with COVID. Every day we see a death is an elderly patient. Yeah, and let's say they're admitted to the hospital. Can you imagine the number of devices that is fixed on them in the ICU, which is also contributing to the infection rate? Not only COVID, but other infections as well.
Yep.
Yeah. So that is why the death rate is high too.
Yes, of course. Yeah, okay. So that's the explanation from Dr. JEYA. So maybe, Mom, we are next moving to the next questions. Maybe Mr. Sukarmin continue the questions. So the question is, how much reduction in the incidence of diabetes can be reduced by using a good standard or intravenous therapy? In Indonesia, our country, the incidence of diabetes from IV therapy is still quite high. So what was that? That's
incidence of phlebitis?
Yes. Yes.
Are you talking of phlebitis? Sorry?
Yes, Mom. Yes. Yes, doctor.
You're talking about incidence of phlebitis is very high, is it?
Mm-hmm. Yeah. So the question is how much reductions?
Well, the global standard for phlebitis should be less than 5%.
Okay.
So that is our standard. So phlebitis is definitely an indicator, not only for elderly, but every patient that is admitted into the hospital. And phlebitis definitely is occurring every day. We cannot avoid it sometimes. But what is happening is we do not follow proper, what we call ANT. We have to strictly follow aseptic technique when dealing with any procedures, whether it's elderly or whether it's other patients who are on vascular access device. So one of the things that Infusion Nurses Society has recommended this time is that we strongly adhere to ANT, and especially now, well, when we are talking about ANT, non-touch technique, many of the healthcare professionals definitely don't use non-touch technique, yeah? They tend to use their bare hands sometimes, or sometimes they wear gloves, and the gloves is not changed in between patients. So that is not non-touch technique. So the increase in phlebitis, yes, we have, but we have a lot of cases here in Malaysia as well, and that is our indicator that we should make sure that it's not more than 5%. Let's keep it to less than 5%. But the elderly, they are the ones who are being, we have a lot of cases with the elderly who have not only phlebitis is very high, infiltration is very high, and if the patient is on a vesicant drug, we also have extravasation.
Okay, so that's the explanation from Dr. JEYA to Mr. Sukarmin. Hopefully it answers your questions Very well.
Is it quite clear? I hope I got the right answer for you.
Okay, yes, of course. And do we have still questions in our chat room? Or someone raising hands? Yeah, I think this topic is really, really interesting. And okay, we still have more questions? No? Right? Yeah, okay, so, okay, Dr. JEYA, so we have one participant here would like to ask you directly. So, Mrs. Zumi Farida, so the floor is yours now.
Okay.
Okay.
Okay. Hello, Dr. JEYA. Long time no see you and communication with you. Okay. Thank you for the opportunity. I would like to ask about the elderly in the community.
Yes.
Okay, as we know, in Indonesia still COVID-19 is high incident, and then how to prevent elderly in the community with the diabetes, and because it's about the condition that elderly need to electrolyte or some of water, but commonly elderly they didn't want to drink more water. How to prevent in the community, include with the family support? I think this is my question. Thank you so much.
You're talking about dehydration in the elderly. They don't drink the water. That's the reason now. I do not know whether you all in the community in Indonesia set lines in the home, in PIVCs at home to give IV infusion therapy. Here we are encouraging more of, at the moment, our nurses are not doing it in home care, setting up IV therapy, but this is where we are recommending that all community nurses learn how to set up lines in the homes, so that the patient sometimes a elderly patient does not need to be admitted into the hospital. The better that we keep the elderly patient away from the hospital is good, isn't it? We can do a lot of things for the elderly, especially the COVID pandemic has taught us a lot of lessons that infusion therapy can be done at homes. We can, for patients who are dehydrated, we can actually put up PIVC lines at home and just give them the infusion therapy at home. They don't have to be admitted. If the patient requires antibiotics, we can give it in the house, antibiotic injections intravenously. They need not be admitted to the hospital. So as community nurses, I think this is one area that we are also trying to emphasize is vascular access for the elderly, is that they learn the proper technique of inserting the PIVC line. Now, many of the patients, elderly patients, sometimes require a PICC line. In Malaysia, for instance, nurses are not allowed to set up a PICC line. It is a doctors who set up the PICC line. But globally now, even in Singapore, the nurses are being taught to set up PICC lines even at homes, so that the patients can get parenteral nutrition through the PICC line, especially the elderly patients, the chemo patients. We have a lot of elderly with chemo, right? Cancer patients. So in COVID-19, a lot of these elderly patients were dying. Why? many of the things was, number one, we couldn't get them into the hospital. Number two, they were the least priority, kan? The warga emas was the least priority in the hospital setting to be admitted, right? Am I right?
Yes, of course.
It is a choice, right? So
Yes,
why can't we? Yeah. So my question during the COVID-19 was, together with our society, was if all our community nurses were allowed to set up IV lines after assessment, we need not admit these patients to the hospital, especially those in level 1, level 2 COVID cases as well, right?
Yes, of course.
So for me, it's very important that nurses are allowed to insert lines, especially PIVC, they should be proficient in it. PICC, we should start teaching our nurses how to do a PICC line as well. Under supervision first, then leave them to set. Yeah. Yes,
Okay.
the elderly,
Right.
most neglected patients during the pandemic.
Right, so very, very amazing explanation. Yeah, so hopefully to Mrs. Umi, so hopefully it answers your questions. And okay, do we still have more questions in our chat room? No? No? Okay, so yeah, this is a really, really interesting topic to discuss today with Dr. JEYA. But unfortunately, so the time is now running out.
Yes,
Then
I
maybe
understand.
I will close this session. But before I close the second session, so would you please give the closing statement, Mom?
Well, I hope all of you treat the elderly patients with care. And for us, vein preservation is very important. And we want to preserve the vein from the birth to the death. So we hope if all of us have preserved the vein from the beginning, the elderly do not have to suffer when they actually need a vascular access. That's my final remark. Preserve the vein from birth to death.
So, okay, so one more time, so we would like to say thank you and give a virtual applause to Dr. JEYA one more time for the wonderful presentation today. Right, and finally, I must close this session, Doctor, and we see you in the next. We see you in the next presentation. Goodbye, Doctor.
Bye.
Okay. Right, well, ladies and gentlemen, so before we are jumping to the next session, session 3, so yeah, I will inform a little bit to you that TIHTZ, so now open some registrations. If you are interested in joining, so please go to the Facebook and also website of TIHTZ. Okay, and now we will go directly to the next session. The great also presentation will be presented by Mr. Sukarmin. And today he will talk about medical surgical nursing for elderly patient. So let me keep in touch with the Mr. Sukarmin first. Mr. Sukarmin, hello. Assalamualaikum warahmatullahi wabarakatuh. Have you been connecting with us?
Okay. Hello, Mr. Safik.
Okay.
Okay.
Still process of connecting. We're still waiting for the connection for Mr. Sukarmin.
Okay.
Okay. Right. So yeah, before he delivers the presentations, let me read his curriculum vitae first. So his full name is Sukarmin. So he was born in Pati, 7th of May. And now he lives in Japan, RT2 and RW1 Metropo. So now he is a lecturer in our University of Muhammadiyah, Kudus. And about the educational background, so he completed the Diploma of Nursing from Magelang in 1998, and she continued to the bachelor degree of nursing in Universitas Muhammadiyah Yogyakarta, and continue for the master degree of nursing also in University of Indonesia. And 2013, so she takes the specialist for K.M.B. And about the professions that he had along with this institution. So in 2008, so he helps for the director in Akbar Muhammadiyah Kudus, and also he had to be vice director one in A.Kes Muhammadiyah Kudus. In 2019, so she was a head of Pusat Al-Islam Muhammadiyah, and now so he will the vice dean of faculty of health in our university. Okay, to save our time, so let me give a turn to Mr. Sukarmin to deliver the presentation. Now the floor is yours, sir.
Okay, hello. Okay, thank you for Mr. Safik as moderator who has given me time to transfer my material today. Okay, how are you today? Kaifa kaluka? Kaifa kaluk? Ya akhi wa ya ukhti. Bagaimana kabarnya ini peserta seminar yang berbahagia? Okay, before I'm talking a lot discussion first, I would like to introduce myself. My name is Sukarmin, Magister Keperawatan Spesialis Keperawatan Medical Bedah, Master of Nursing Medical Surgery Specialist, PhD of Health Science Faculty, University of Muhammadiyah Kudus. I am able to attend in this forum because I have known more health master and specialists from various countries, especially Taiwan, Malaysia, and Indonesia itself. They are from Professor JIN-RU of National Taipei University of Nursing and Health Science Taiwan, and Dr. DEVI COOMASAMY, Education Consultant and President of Infusion Nurse Society of Malaysia, and Mrs. Anny Rosiana Masithoh, Magister Keperawatan Medical, Spesialis Keperawatan Jiwa. Okay, on this occasion, I will discuss management elderly illness in Indonesia. According to the Ministry of Social Affairs, the population of Indonesia, as voted by 60 years old and more, is rate 28.7 billion people in 2020. Aging is a natural process. Physiological change occurs with aging in all organ systems. All age is event that has been determined by Allah Subhanahu wa Ta'ala, as stated in the Quran Surah An-Nahl 70. A'udzu billahi minasyaitonir rajim. Wallahu khalaqakum tsumma yatawaffakum wa minkum man yuraddu ila ardhilil umri likay la ya'lama ba'da ilmin syai'a. Innallaha alimun qadir. Oke, jadi Bapak Ibu, ini adalah surat Al-Qur'an di surat An-Nahl ayat 7 yang menyampaikan bahwa Allah telah menciptakan manusia, kemudian memanfaatkan sebagian, kemudian ada yang dikembalikan kepada kondisi di mana menjadi tua renta. Nah itu ya, jadi Bapak Ibu yang saya hormati peserta seminar, jadi proses menua ini adalah proses di mana perjalanan alamiah, dan nanti kita akan mengalami semua karena ini sebagai proses yang sudah menjadi sunatullah. Nah, ada beberapa proses yang kemudian terjadi di usia lanjut. The cardiac output decrease, jadi adanya penurunan cardiac output, blood pressure increase, and arteriosclerosis development. Nah, ini yang kemudian menjadi trigger bahwa di usia lanjut itu banyak terjadi gangguan, terutama adalah gangguan-gangguan yang berkaitan dengan kardiovaskuler. One illness in elderly, degenerative joint disease or osteoarthritis. More than 50% of adults over the 65 years are affected by degenerative joint disease. The condition is associated with pain, loss of function, and reduced endurance, ultimately leading to weight gain and associated complications. Osteoarthritis experienced by all age will result in many disruptions to daily activity, such as difficulty bending the leg when sujud. Jadi ada banyak keluhan yang kemudian memunculkan penyakit osteoartritis itu. Salah satunya kalau di negara kita karena mayoritas muslim itu banyak keluhan yang muncul, salah satunya itu yang terbanyak di beberapa survei itu adalah rasa sakit pada saat sujud atau kesulitan pada saat sujud. Kemudian hal lain yang bisa timbul akibat gangguan osteoartritis di negara kita itu adalah slow when walking to the bathroom. Jadi banyak juga yang kemudian mengalami kesulitan pada saat mau ke kamar mandi. Yang keluhannya cukup banyak, ada yang kemudian merasa nggak mampu, kemudian merasa ada kesulitan pada saat menuju ke kamar mandi. Nah, ini risk factor. Predisposition factor include repetitive motion, infection, rheumatoid arthritis, post-joint trauma, muscular dystrophy, osteoporosis, hormone disorder, obesity, sickle cell disease, and bone disorder. Infection of the joint muscle atrophy, menopause, decreased lubricant in the joint should be a concern of the nurse when conducting assessment in all age, because the condition is the most common factor in joint disorder. Jadi pasien-pasien yang sudah menua dengan kondisi muskuloskeletal yang mengalami distrofi dan adanya penurunan matrik tulang, ini biasanya yang terbanyak kondisi yang relevan itu adalah pada saat untuk wanita ini pada kondisi di mana terjadi menopause. Ya, jadi itu yang relevan. Ini juga berkaitan dengan bagaimana terjadi penurunan dari tingkat hormonal sehingga nanti memunculkan banyak gangguan seperti penurunan massa otot, kemudian gangguan tidur, kemudian bisa juga mengakibatkan depresi pada lansia. History and symptom, patient may have pain, stiffness, limited range of motion, loss on flexibility, swelling, weakness, deformed joint, and demarc cartilagu. Based on interview with patient in the clinic, factor of work history by lifting heavy weight such as farmer, porter, construction worker, and stone quarry digger, and the large group the experience joint disorder. Jadi ada beberapa riwayat yang kemudian bisa kita tarik di negara kita itu adalah orang-orang dengan resiko pekerja berat seperti petani, kemudian kuli panggul, gitu ya, itu menjadi faktor lansia yang kemudian dapat mengalami kondisi di mana terjadi gangguan pada persendian. Nah, pada saat muda mungkin tidak muncul, akan tetapi di saat tua kemudian banyak muncul problematika di situ. Nah, treatment method, jadi physical examination will focus on the joint range of motion atau yang sering kita sebut dengan ROM. Ini merupakan salah satu pilar utama untuk gangguan-gangguan yang berkaitan dengan persendian pada usia lanjut. Nah, ini perlu kita programkan karena program ini adalah program yang sangat murah, mudah dilakukan di usia lanjut, dan juga bisa meningkatkan tingkat produktivitas yang bisa dialami oleh pasien-pasien dengan usia lanjut. Nah, itu jadi yang kedua ini adalah cardiovascular disease. Cardiovascular disease remains to the most common cause of death of older adults. After death rate have dropped in last 20 years. This category include chronic ischemic heart disease, congestive heart failure, and arrhythmia. Prevalence of coronary heart disease, stroke, or other atherosclerosis disease estimate the year for CVD, cardiovascular disease, rise of more and less 30%. Jadi cardiovascular disease ini termasuk salah satu penyakit yang banyak dijumpai pada usia lanjut, di mana angka kejadiannya cukup tinggi, jadi sekitar 30%. Jadi kalau ada 10 lansia, maka 3-nya ini mengalami gangguan kardiovaskuler. Ini angkanya cukup tinggi gitu. Nah, yang jadi pemicu itu adalah gangguan arteriosklerosis, di mana the arteriosklerosis, which is the main cause of cardiovascular disorder in all age, is caused by damage to the tunica of blood vessel due to the formation of plaque derived from the buildup of lipid in the blood and high blood sugar and blood in vessel infection. Jadi penyebab utama yang bisa menjadikan terjadinya arteriosklerosis itu terutama adalah pembentukan plak yang dipicu oleh asupan lipid atau lemak yang berlebihan. Selain itu juga terjadinya peninggian kadar gula darah. Nah, ini biasanya terjadi pada lansia yang mengalami DM atau diabetes mellitus. Nah, ada beberapa teknik. Jadi many authors are surprised of find that the can prevent and significantly lessen an effect of cardiovascular disease by making even small adjustment in the daily routine. Jadi ada beberapa manajemen yang bisa kita terapkan untuk pasien-pasien kita yang mengalami lansia. Yang pertama itu adalah manage blood pressure. Jadi memanage bagaimana supaya kondisi tekanan darah itu menjadi terkontrol gitu. Ya, jadi ada beberapa cara. Kalau di Indonesia itu penggunaan obat itu menjadi pilar utama. Ya, jadi menjadi pilar utama. Karena satu, mempunyai reaksi yang cepat, kemudian yang kedua, obat-obatan itu juga mudah untuk dipakai dan juga dengan efek samping di beberapa obat itu yang kemudian efek sampingnya itu cukup sedikit. Kemudian yang kedua adalah stay physical aktif. Jadi latihan aktivitas yang juga bisa memacu bagaimana jantung kita itu bisa memompa dengan efektif dan baik. Gitu ya. Kemudian yang ketiga ini yang menjadi pilar penting adalah eat nutrition. Jadi ada beberapa pilar yang harus menjadi garis bawah kita. Itu adalah yang paling penting itu adalah ini. Jadi pemberian nutrisi dengan tinggi serat. Ya, jadi tinggi serat itu diharapkan dapat meningkatkan kadar air, kemudian juga membantu proses metabolisme sehingga residu metabolisme itu tidak banyak tersisa di dalam tubuh kita, sehingga relatif pembentukan plak yang terjadi di kardiovaskular itu menjadi lebih sedikit. Kemudian yang selanjutnya itu adalah hypertension. In Indonesia, the prevalent rate of hypertension has dramatically increased from 25% and 8%. Jadi ini angkanya cukup tinggi, jadi sekitar 25,8%. Prevalensi hipertensi di Indonesia itu mengalami peningkatan dan naik menjadi 34,1% di Indonesia ya. Jadi naiknya cukup tinggi. Nah, karena hipertensi ini merupakan salah satu penyakit yang berkontribusi terhadap angka kematian lansia yang cukup tinggi, maka kita harus berperanan baik dalam hal penurunan tekanan darah. Ya, jadi ada beberapa pilar yang bisa kita sampaikan ke pasien kita, bagaimana caranya untuk menurunkan. Nah, ini ada satu hal yang menarik, di mana ini ya, jadi several clinical trial have clearly demonstrate that treatment of hypertension significantly reduce to cardiovascular event rate. However, controversy continues as to the choice of antihypertensive agent and combination of agent. Jadi Bapak Ibu yang saya lihat banyak peserta dari rumah sakit ini memang masih menjadi kontroversi ya. Jadi pasien-pasien hipertensi yang diobati secara kontinu terus-menerus itu apakah baik apa tidak gitu. Tapi ada beberapa riset derivat yang dari golongan kaptopril itu dianjurkan untuk bisa dikonsumsi seumur hidup. Sementara golongan lain seperti kalsium channel blocker atau yang sering kita sebut dengan amlodipin itu tidak dianjurkan menjadi derivat terapi seumur hidup ya. Jadi itu kira-kira untuk pesannya di hipertensi yang berkaitan dengan lansia. Yeah, in Indonesia, hypertension is still most common disease with the most prognosis for stroke and heart disease. Hypertensive patients who are not managed properly will cause many problems in the elderly, including extreme disability, memory impaired to death. Jadi ini kalau hipertensi ini tidak kita kelola dengan baik, ya maka bisa mengakibatkan banyak hal. Salah satunya adalah serangan jantung. Juga bisa mengakibatkan gangguan yang nanti bisa memicu gangguan memori. Nah, salah satunya itu dipicu oleh serangan stroke. Ya, jadi makanya ada beberapa kondisi ketika pasien-pasien kita itu tidak diterapi baik, kemudian jatuh pada kondisi stroke, di mana pasien kemudian lupa akan hal-hal yang sudah dilakukan selama ini. Misalnya ada yang lupa anaknya, kemudian ada lupa jalan untuk bisa pulang. Lifestyle modification is recommended as the first line treatment for all patients with hypertension, especially in elderly population where polypharmacy potential drug interaction and not adherence to treatment regimen are serious concern. We control adoption of the dietary approach to stop hypertension. Dietary sodium restriction, increase activity level, and limiting alcohol intake are effective tool in the treatment of hypertension. Jadi perubahan pola hidup seperti meningkatkan olahraga, kemudian mencegah makanan yang berlemak, menghindari rokok, kemudian ini ya, jadi ini beberapa riset yang sudah dipopulerkan melalui sebuah riset bahwa pasien-pasien hipertensi ini sebetulnya cukup mengkonsumsi 10 gram NaCl, 10 gram garam dapur ya maksudnya. Jadi 10 gram garam dapur itu kalau ditakar itu sama dengan 1 sendok teh untuk semua masakan. Nah itu bisa kita bayangkan bagaimana rasanya ya. Ya ini yang kita sebut dengan dietary sodium restriction. Kemudian activity level increase, ini harus aktivitas fisiknya harus kita naikkan. Tentunya harus ada rambu-rambu ya. Jadi yang jadi rambu-rambu salah satunya adalah heart rate atau denyut jantung. Nah nanti kita harus belajar lagi denyut jantung target itu tidak boleh melebihi denyut jantung maksimal. Jadi yang boleh cuma 80%. Jadi kalau ada usia lanjut punya denyut jantung itu 180, maka ketika dia aktivitas tidak boleh melebihi 180. Dia harus maksimal 80%-nya yang bisa kita pakai. Jadi sekitar 130, 140 gitu ya. Itu yang bisa kita pakai. Nah, ini yang jadi problem selanjutnya adalah diabetes mellitus. Jadi diabetes mellitus frequency is growing problem worldwide because of long life expectancy and lifestyle modification. Jadi ini adalah problem yang harus menjadi fokus selain kardiovaskuler, itu adalah diabetes mellitus. Jadi pasien-pasien usia lanjut yang sudah mengalami diabetes mellitus itu salah satunya itu karena adanya problem sebelumnya itu adalah di lifestyle. Jadi lifestyle atau yang kita sebut dengan gaya hidup gitu, terutama adalah gaya hidup yang sering mengkonsumsi gula dengan kadar yang cukup tinggi. Nah, itu yang terjadi di negara kita. Nah, glibenclamide, glimepiride, and metformin are the main choice of the controlling blood glucose in the elderly in Indonesia. These medication are usually prescribed by a doctor and blood glucose control will at home. Jadi ini saya sampaikan, jadi Bapak Ibu selama ini kan di negara kita itu sering menggunakan gliben, metformin, terus glimepiride sebagai pengobatan untuk mengontrol gula darah di rumah. Nah, obat-obatan ini tentunya harus melalui kontrol yang cukup bagus, terutama adalah kontrol gula darah. Sehingga pasien-pasien kita itu nanti, terutama yang usia lanjut, itu bisa kita kontrol dengan baik gula darahnya, sehingga nanti tidak akan terjadi kondisi di mana akan terjadi kondisi beberapa hal. Salah satunya adalah tidak terkontrolnya gula darah, baik itu kondisi hipoglikemia maupun hiperglikemia. Jadi itu yang menjadi faktor penting yang bisa kita sampaikan pada pasien-pasien kita, sehingga nanti kita bisa memanage dengan baik. Okay, thank you very much, Mr. Syafiq.
Right, so that's the wonderful presentation from Mr. Sukarmin about the elderly. Of course, after this, I will go directly to discussion session or question and answer session. So I will invite all the webinar participants to join the question and answer session by raising hand and also by writing your questions in our chat room. So please, if you have any questions.
Ya, monggo kalau ada yang tanya, bahasanya gado-gado ya Pak Syafiq ya.
Ya, tidak apa-apa. So please, everyone, so you can ask both in bahasa Indonesia or in English, it's okay. Is there any questions?
Ya. Hah?
Okay. Okay, is there any questions through our chat room? Well, ladies and gentlemen, so, okay, well, inviting all of you to write down your questions or even raising hand. So, So I would like to point one more time, this international webinar is done in a collaboration with TIHTZ, Taiwan. So I would like to say thank you very much for convener of Taipei Hospital and Taiwan International, so to support this conference. Okay. Do we have questions through our chat room? Well, ladies and gentlemen, you can both asking in Bahasa Indonesia or even in English. Yeah, both of them are acceptable. So if you have any, so just writing your questions through our chat room, or you can ask directly by raising your hand virtually. Yeah, okay, so the first questions from Pak Suparno to Mr. Sukarmin. So the question is, pertanyaan untuk Pak Karmin, kenapa pasien DM itu rata-rata malas untuk beraktivitas dan olahraga? Adakah solusi dan pengganti selain olahraga agar tetap terjadi pembakaran gulanya, Pak? So that's the question, Pak Karmin. So you may give your explanations about that.
Ya. Oke, thank you Mr. Parno ya. Matur nuwun Pak Parno. Jadi pertanyaannya ini rata-rata malas untuk beraktivitas itu, yang pertama biasanya memang usia lanjut itu kan ada penurunan banyak ya Pak, terutama adalah masa otot gitu, sehingga wajar kalau kemudian merasa malas karena merasa nggak mampu gitu. Nah, ada beberapa solusi sebetulnya yang tadi juga sempat saya singgung itu, terutama di perawat, itu adalah bagaimana kita bisa membentuk komunitas lansia Pak. Nah, komunitas itu juga bisa bermanfaat untuk saling memberi support dan berbagi gitu. Jadi kalau misalnya Pak Parno ada temannya diajak cerita, itu mesti lebih antusias melakukan daripada melakukan sendiri. Nah, terkait dengan pengganti pengganti aktivitas untuk bisa membakar lemak itu, kalau kita lihat berbagai jurnal itu ya nggak ada Pak, cuma tingkatannya aja yang berbeda. Yaitu aktivitasnya bisa dilakukan di rumah menggunakan alat-alat exercise seperti cycling itu, jadi ada sepeda statis namanya Pak, sepeda statis itu juga bisa dipakai. Nah, cuma kan ada beberapa masyarakat kita yang nggak mampu untuk bisa membeli dengan baik gitu. Nah itu ya, jadi saran saya untuk Pak Parno yang kebetulan mungkin di puskesmas bentuk komunitas lansia Pak, yang sebetulnya ini sudah banyak terbentuk juga sehingga bisa tinggal kita mengaktifasi.
Yeah, so that's the answer from Mr. Sukarmin, begitu ya Bapak, Pak Suparno yang bertanya kepada Pak Karmin tentang DM. Baik, so is there any more questions? Ada pertanyaan lagi? Okay, so the next questions coming from Ibu Amalia Rahmawati addressed to Mr. Sukarmin. The question is, pertanyaannya, bagaimana penata laksana stroke yang baik dan benar, khususnya bagi keluarga dengan background non-kesehatan. So that's the question, Mr. Sukarmin.
Oke, thank you. Jadi untuk orang awam ya, jadi untuk orang awam bagaimana cara memberi penata laksana yang baik pada pasien stroke? Sebetulnya kalau belum terkena yang paling baik itu kan preventif ya, atau pencegahan. Tapi kalau sudah terkena bagaimana? Kalau sudah terkena berarti kita mengembalikan fungsional. Kalau memang yang nggak berfungsi itu adalah ekstremitas, berarti latihan ekstremitas. Kalau yang nanti terkena itu adalah pusat bicara, di mana kesulitan bicara atau yang kita sebut dengan afasia, maka akan dilatih untuk berkomunikasi gitu. Nah, sebetulnya latihan yang dilakukan orang-orang yang mengalami gangguan itu sebetulnya seperti tahap tumbuh kembangnya anak-anak gitu ya. Jadi kalau kesulitan bicara, kenapa yang dilatih itu huruf vokal dulu, mesti A, E gitu dulu, karena itu sesuai dengan proses tumbuh kembang. Kalau konsonan yang dilatih itu kesulitan, jadi itu nanti bisa dilakukan seperti itu. Kemudian kalau yang kesulitan di gerak itu untuk orang awam, ya latihlah pada pergerakan yang ringan, misalnya menekuk tangan, jari, dan lain-lain, itu seperti itu. Ya, jadi itu panduan untuk orang awam. Tapi ini menjadi ide bagus, mungkin bisa kita susun panduan perawatan stroke untuk orang awam. Ya, oke, seperti itu Pak Syafiq.
Okay, well, so that's the answer and explanation from Mr. Sukarmin. Begitu tadi ya, sudah dijelaskan secara rinci oleh Bapak Sukarmin kepada Ibu Amalia Rahmawati. Semoga sudah terjawab pertanyaannya. And then, is there any more questions? No? Or someone raising hand? No. Okay, so yeah, I believe this topic is really interesting. If you still have a question, you can send your question to our email, and then we will drop directly to Mr. Sukarmin. Jadi kalau masih ada pertanyaan, silakan dikirim ke email, dan nanti akan kami sampaikan Pak Karmin untuk mendapatkan jawabannya. Right, so before I end this session, so I will ask Mr. Sukarmin to give a please closing statement, sir.
Yes, oke. Jadi ini closing saya, usia lanjut itu sebagai usia yang berjalan alamiah, mesti bakal terjadi pada siapapun yang disebut dengan manusia, dan akan diikuti dengan penurunan berbagai fungsi. Tadi juga sudah banyak disinggung. Maka antisipasi kita yang terbaik itu adalah bagaimana bisa menghambat laju penurunan itu menjadi patologis, atau yang kita sebut dengan disorder itu. Jadi menjadi kelainan yang kemudian bisa mengganggu kita pada masa tua kita. Terima kasih banyak atas atensi dari Bapak Ibu. Semoga panjenengan semua mendapat ilmu hari ini. Jadi ada yang dari Taiwan, kemudian Malaysia, nanti juga dilanjut dengan Bu Anny. Mudah-mudahan bisa menambah ilmu untuk Bapak Ibu semua. Okay, thank you very much.
So you are most welcome, Mr. Sukarmin. And once again, so now please give a virtual applause to Mr. Sukarmin for a wonderful presentation. We see you in the next presentation, sir. So I end this session for Mr. Sukarmin's presentation. Thank you. And now we are moving to the last session, session 4, the presentation delivered by Mrs. Anny Rosiana Masithoh. So before she deliver the presentation, so let me keep in touch first with the Mrs. Anny. Hello, Bu Anny. Assalamualaikum. Have you been connecting with us?
Waalaikumsalam warahmatullahi wabarakatuh.
Okay, seems that we have been connecting with Anny Rosiana Masithoh. So today, she will talk about inserting a peripheral intravenous device in an elderly patient. Sorry, so or loneliness among elderly. Right. Before she deliver the wonderful presentations, let me read her curriculum vitae first. Her full name is Anny Rosiana Masithoh. Now she is living in Desa Pasuruan Lor, RT 4 NRW 4, Kecamatan Jati Kudus, Central Java, Indonesia. And she was born in Kudus, 16th of August 1978. And about the educational background, so she completed the bachelor degree from Universitas Pajajaran as a nursing in 2002, and she continued the master degree of nursing also from University of Indonesia in 2011, and she takes the specialist in mental specialist from University of Indonesia also in 2012. So maybe this is the short curriculum vitae of her. So to save our time, now we will go directly to the presentation delivered by Mrs. Anny Rosiana Masithoh. The floor is yours.
Okay. Thank you, Mr. Safik, for introduce myself. Assalamualaikum warahmatullahi wabarakatuh. Baik, pada siang hari ini di webinar internasional, alhamdulillah ini adalah rangkaian seri webinar yang keempat yang diselenggarakan di Universitas Muhammadiyah Kudus. Saya akan menyampaikan materi tentang kesepian pada lanjut usia. Ini merupakan suatu hal yang sangat menarik dari seluruh rangkaian pemateri-pemateri yang hari ini sudah disampaikan terkait dengan elderly. Jadi tadi sudah ada pembahasan tentang bagaimana kondisi-kondisi fisik dan penyakit-penyakit yang banyak diderita oleh lansia, dan ini saya kaitannya dengan kondisi psikologis yang dialami oleh lansia, terutama adalah kondisi-kondisi di mana lansia ini banyak yang mengalami kesepian. Ya. Baik, ini sambil menunggu share screen-nya. Bisa share screen sendiri atau dari sini? Oh, enggak share screen. Oh iya, sini. Oh, enggak ada. Materinya. Ya baik, sambil menunggu share screen untuk materi saya. Baik, Bapak dan Ibu peserta, perlu kita ketahui bahwa untuk saat ini di seluruh dunia ya, tidak hanya di Indonesia, itu untuk angka dinamika usia-usia dari penduduk yang ada di dunia ini sudah mulai merangkak bahwa lansia ini menjadi angka yang cukup tinggi. Ya. Nah, ini sudah bisa dilihat terutama ada di Jepang. Ya, ini sudah mulai untuk yang saat ini di negara-negara berkembang yang tadinya adalah didominasi oleh usia produktif yang paling banyak. Sekarang ini sudah memulai bahwa angka harapan hidup ini sudah mulai memanjang. Jadi banyak sekali usia-usia lanjut yang perlu nanti lebih banyak diperhatikan, begitu. Nah, ini adalah prolog, dan kalau kita melihat bahwa angka harapan hidup ini nanti semakin tinggi, ini maknanya diikuti oleh bagaimana nanti proses degeneratif ini nanti muncul, dan ini sebaiknya nanti akan menjadi concern dari pemerintah. Nah, sebelum kita berbicara concern dari pemerintah, mungkin kita perlu melihat, tadi sudah banyak disampaikan terkait dengan kondisi fisik, proses-proses degeneratif, dari mulai proses degeneratif, mulai dari saluran pernafasan dari ujung rambut sampai dengan ke ujung kaki, sampai dengan ke kulit tadi sudah banyak sekali didiskusikan, dan sangat menarik sekali karena usia ini adalah usia yang sebenarnya diperjuangkan oleh kita semua, bahwa semuanya mempunyai angka usia harapan hidup yang tinggi. Itu baik. Ini saya mulai untuk share screen-nya. Elderly is defined as a chronological age of 65 years old or older, while 65 through 74 years old as the early elderly, and those over 75 years old as late elderly. Based on WHO, the elderly represents 12% of the world population, and this figure is expected to double by 2050 and triple by 2100. The high total of elderly creates the healthy aging. Worldwide, the relative and absolute number of adults and older people is growing rapidly, and the problems of old age and aging is becoming global. Next. Okay. Old age is a natural and inevitable process occurring final age. An aging population reflects the increasing proportion of older and elderly people in a corresponding decrease in the proportion of young people. Next. Okay. So we can see the graphic. Young children and older peoples are a percentage of global population. Next, according to WHO, 2018, between 2015 and 2050, the proportion of the world population over 60 years will nearly double from 12% to 22%. By 2020, the number of people aged 60 years and older will outnumber children younger than 5 years. In 2050, 80% of older people will be living in low and middle income countries. The pace of population aging is much faster than in the past. All countries face major challenge to ensure that their health and social system are ready to make the most of this demographic shift. Oke. Seperti yang saya sampaikan di awal tentang proyeksi penduduk lansia di tahun 2010 sampai dengan di 2035. Jadi bisa dilihat untuk angka kenaikannya proyeksi sampai dengan di mulai dari 2020 sampai 2035. Kita langsung lihat saja angka kenaikannya sampai dengan di 2035, 15,77% dari total penduduk di Indonesia itu adalah lansia atau sekitar 48,2 juta jiwa. Nah, ini nanti kita harus bisa melihat dan bisa difikirkan bersama nanti bersama pemerintah bagaimana untuk penanganannya baik secara fisik maupun secara psikologis. Next. Three things that have been changed in the elderly period. Number one is economic status. Economic status has significant impact in the whole elderly life, and it's also important determinant of health, habits, social interaction, and also participants in the social life. Number two is health. In the health status aspect, elderly has potential health risk, functional disorder, inappropriate nutrition, social exclusion, and chronic illness. Number three, limited social contact. In the limited social contact, it becomes one of the problems for elderly because some cases lead to complete social exclusion. The main reason for the limited social contact is limited physical mobility. They also limited contact among their families, friends, and community because their psychological and pathological also change. Next. Okay, so now we talk about loneliness. Elderly and loneliness have close relationship because with decreasing condition such as sickness, death of spouse, family matters, meaningless life, lack of friend, absence of relative, and living conditions were causes of feeling lonely. Next. loneliness as the silent pandemic of aging population. Next. Okay, we see about what is the difference about loneliness and social isolation. Okay, loneliness as a subjective concept as a result of perceived absence or loss of companionship as a result of bereavement of geographical separation. Loneliness is always involuntary. What about social isolation? Social isolation is objective concept that refers to the negative feelings resulting from the absence of meaningful relationships and social integration. So social isolation can be either voluntary and or involuntary. Next. Okay. In the past, there was greater contact between the older adults and their children. However, the change in family patterns and community structures has gradually reduced intergenerational contact. According to Murayama et al., 2019, older adults, especially those living in adult care facilities, experience social isolation when they were deprived of the opportunity to use their given skills and energy, and eventually resulting in them experiencing discouragement, frustration, and depression. An increase in urban living has also lessened the opportunities for ongoing contacts between the younger and older generations, resulting in children not understanding the needs and ability of older adults and causing the older adults to often forget the positive emotional benefit of being around young children. Next. Okay, there is two types of loneliness. Number one is emotional loneliness and social loneliness. The emotional loneliness is a strong predictor which affects life quality with compare with social loneliness. Okay, this is social loneliness because of aging, health problems, living in the country, low communication with friends, and reducing of incomes. Next. Okay, this is emotional loneliness because of family status, getting the divorce or never marrying, or restrict visits of children, or living alone. Next. Loneliness felt by elderly individuals left in a nursing home is higher than those who have close contact with family members. Family visits are vital to these elderly individuals because creates a feeling that he or she is important and needed by the family. Next. Okay, there's a lot of factor affecting the appearance of loneliness in the elderly. One is low social communication. Number two, factor which result from physical and demographical condition and which affect the individual psychological living alone. Have low social communication, experience intensive sadness, not being visited by especially friends and siblings, loss of spouse, being divorced because aging, low education level, being physically disabled, using drugs permanent and not having any hobbies, being deprived of social support, physical inactivity, various illness, loss of a relative, physical and mental weakness, and reducing of incomes. Living away from sons and daughter and neighbors, low self-respect, not being content with the living space, being completely dependent on others in daily activities, increase loneliness in the elderly. Okay, next. So, what should we do to help the elderly to communicate with their friends or community by joining in some activities like religious activities, or we can call pengajian in Indonesia, or social activities, or the others. If they cannot meet directly, the communication can be done by phone or video call. Number 3, help them to do some activity such as reading, writing, listening to the music, watching television, shopping, walking around, gardening, fishing, or the other. Number 4, all of the family members must support the elderly by caring, visiting, and the other. Okay, this is my presentation. Thank you. Mr. Safik, saya kembalikan. Terima kasih.
Right, so that's the wonderful presentation from Mrs. Anny Rosiana Masithoh about elderly. And to comprehend your understanding about the presentation, once again, I invite you after this to a question and answer session. So, all webinar participants, you can join the discussion or question and answer session by writing your question in our chat room, or just press raise hand columns, yeah, to ask directly to Mrs. Anny Rosiana Masithoh. Okay, now, so, right, I open a question and answer session, please. Is there any questions? Okay, so, we have first questions. Yeah? Okay, right, so the questions from Mrs. Fatimah Nur Asia to Mrs. Anny Rosiana Masithoh. The question is, how to know that elderly feel loneliness or not? So that's the questions, Mom.
Saya langsung jawab?
Yes, of course.
Okay. Thank you, Mrs. Fatimah. Saya jawab dalam bahasa Indonesia, oke ya?
Oke.
Nanti dibantu Mr. Safik untuk translate. Baik, bagaimana kita tahu bahwa elderly ini merasa kesepian atau tidak? Jadi, kesepian ini adalah sifatnya sangat subjektif sekali. Karena sangat subjektif, memang harus kita explore. Jadi, kita memang tanyakan kepada lansia, dan yang menanyakan kepada lansia ini memang orang yang benar-benar diberikan trust, atau lansia ini memang dekat atau percaya kepada ya katakanlah yang mengkaji tadi, ya. Jadi memang yang namanya loneliness ini adalah sebuah ungkapan, karena subjektif itu kan tidak bisa dilihat hanya dari luarnya saja. Jadi orang yang kesepian itu merasa walaupun di sekitarnya banyak orang, tapi perasaannya itu kesepian. Karena kita bisa lihat nanti dari berbagai macam penyebab. Kalau nanti kita kaji, misalnya pada elderly ini ada beberapa hal yang bisa menyebabkan seseorang ini menjadi kesepian. Ada saat dimana dia ditinggalkan oleh pasangannya. Ditinggalkan tidak bisa jadi karena meninggal, bisa jadi karena divorce. Terus anak-anaknya jauh, ya jauh dari keluarga, dari anak-anak, jauh dari cucu, atau ditempatkan di panti urida. Ditempatkan di panti urida ini juga belum tentu dia merasa kesepian, karena ada memang beberapa contohnya lansia-lansia yang ada di negara seperti Jepang, mereka dari awal memang sudah menyiapkan dirinya untuk masuk ke dalam pada saat mereka nanti pensiun atau sudah tidak bekerja lagi atau sudah tidak sudah tidak sehat lagi setelah masa tuanya, itu mereka akan menyiapkan diri sudah masuk ke panti begitu. Jadi karena sudah persiapan dari awal, bisa jadi karena mereka tidak menikah, bisa jadi karena mereka tidak punya anak. Jadi ini mental mereka sudah jauh lebih tertata atau memang sudah siap dari awal. Tetapi kalau lansia-lansia apalagi di budaya ketimuran seperti di Indonesia, banyak sekali lansia yang masih berada di komunitas karena konsep kita adalah konsep birrul walidain. Jadi berbakti kepada orang tua ini memang harus dilakukan sampai dengan lansia ini meninggal, katakanlah begitu. Nah, jadi pada saat di rumah anak-anak ini memang kalau memang itu lansianya ada di komunitas atau di rumah anak-anak juga harus meluangkan waktu. Jadi jangan sampai lansia ini berada di rumah, ada di rumah kita tapi nggak pernah diajak ngobrol atau hanya disapa sebisanya saja. Enggak, kita memang harus meluangkan waktu juga untuk mengajak berkomunikasi, tetap memberikan activity. Jadi lansia ini juga sebisa mungkin diperkenalkan dengan yang seusianya. Aktivitas-aktivitas yang disukai oleh lansia, apakah itu seperti berkebun ataukah pengajian, itu tetap harus diberikan terus, dimotivasi lansianya. Dan cucu-cucunya ini sebisa mungkin didekatkan, ya. Nah, supaya lansia ini tidak merasa kesepian. Kesepian ini diungkapkan. Jadi caranya mengetahui adalah dengan eksplorasi. Apakah lansia ini kesepian atau tidak. Tetapi kalau ingin melihat secara objektif lansia yang kesepian, ini bisa dilihat dari bahwa lansia ini tidak seperti biasanya. Misalnya biasanya banyak berbicara, terus tiba-tiba menjadi murung. Jadi ini sifatnya adalah kita bisa melihat dalam jangka waktu dekat ini apa sih yang terjadi pada lansia. Dan ini biasanya adalah orang-orang dekat atau orang-orang yang memang berada di sekitar beliau ini di saat-saat tertentu sebelum kejadian atau ada beberapa yang perubahan yang terjadi pada lansia begitu. Itu Bu Fatimah atau Mbak Fatimah Nur Aisyah. Yeah.
Okay, so that's the explanations. Baik, tadi sudah dipaparkan dengan sangat jelas oleh Bu Anny Rosiana ya, bagaimana orang tua ini merasa kesepian, bagaimana cara mendeteksinya. Nah, tadi sudah disampaikan ya dalam bahasa Indonesia dan sangat jelas sekali. Now we are moving to the next questions. Question from Ibu Afrika. Bapak Yusuf Indra Putra. Alright. Oke, Pak Yusuf Indra Putra. So the question is, bagaimana cara membedakan feel alone sama loneliness? How to distinguish between feel alone and the loneliness? So that's the questions.
Ya, terima kasih Pak Yusuf Indra Putra. Jadi bagaimana cara kita membedakan feel alone atau merasa sendirian dan kesepian? Ya, jadi kalau perasaan sendirian ini sifatnya adalah akut ya, akut atau bisa kita runut penyebabnya dalam jangka waktu yang tidak begitu jauh ya. Terus feel alone ini biasanya adalah perasaan-perasaan yang dirasakan tidak didominasi oleh lansia begitu. Jadi kalau feel alone itu kadang-kadang misalnya untuk usia-usia yang masih produktif, misalnya baru saja putus pacar, terus tiba-tiba merasa bahwa sendirian, begitu. Ya, ini adalah feel alone. Sementara kalau loneliness, ya kesepian ini adalah bisa jadi adalah kejadian-kejadian ini kejadian-kejadian yang berulang, tidak hanya 1 kali, 2 kali, ya. Tetapi kejadiannya cukup panjang dan dia seakan-akan kalau orang loneliness itu seperti bagaimana cara saya menyelesaikan itu sudah tidak ada. Contohnya gini, kalau lansia dengan anak-anaknya bisa jadi dia merasa bahwa anak-anak saya sudah punya keluarga, anak-anak saya punya pekerjaan, mereka tidak bisa mensupport saya sepenuhnya dan bisa jadi tidak mengunjungi saya. Jadi dia sebenarnya sudah seakan-akan tahu bahwa kondisinya memang begitu. Jadi seakan-akan sudah tidak bisa berubah. Terus saya harus bagaimana? Ya memang saya harus sendirian. Tapi dia kesepian. Begitu. Sementara kalau feel alone mungkin masih bisa mencari solusi begitu. Kalau feel alone bagaimana caranya supaya saya tidak merasa sendirian? Misalnya karena biasanya kalau feel alone ini lebih banyak seperti saya sampaikan lebih banyak terjadi pada usia-usia yang jauh lebih produktif, belum masuk ke usia yang lansia. Jadi masih bisa misalnya carilah teman yang lain atau pergi kemana, atau pergi berbelanja, pergi ke salon atau pergi ke mall atau sekedar hangout misalnya ngopi gitu dengan ini. Jadi lebih mudah untuk diatasi kalau ada feel alone selama kitanya sendiri ini masih punya harapan. Harapan dalam artian gini, saya bisa kok supaya tidak merasa kesepian. Jadi mencari cara. Sementara kalau untuk loneliness pada lansia, seakan-akan deadlock. Deadlock itu maksudnya begini, saya mau bilang ke anak saya bahwa saya kesepian, nanti takut anak saya nanti begini perasaannya, mengganggu keluarganya, mengganggu. Nah, ini adalah deadlock. Seakan-akan itu no way out gitu. Jadi seakan-akan tidak ada penyelesaian. Sementara kalau feel alone itu kan mungkin dia masih bisa gitu. Sementara lansia ini dari segi ekonomi dia tadi sudah berkurang. Dari segi fisik mobility juga dia sudah berkurang. Mau kemana? Aktivitinya juga sudah berkurang. Teman-temannya yang sebaya juga sudah pada banyak yang meninggal. Sementara kondisinya sudah degeneratif. Jadi seakan-akan itu kesepiannya itu tidak hanya karena salah satu sebab saja, tetapi karena banyak sebab yang menumpuk jadi satu. Akhirnya dia bisa jadi menurut dia saya harus bagaimana lagi. Harapannya itu sudah untuk menyelesaikan masalah itu sudah kecil sekali begitu. Nah, inilah yang memang harus benar-benar yang masih muda, anak-anaknya ini benar-benar mensupport, mendampingi di saat-saat seperti ini. Ya, gitu Pak Syafiq.
Right. So that's the really detailed explanation. Tadi dijelaskan dengan sangat detail sekali ya tentang feel lonely sama loneliness. Nah, tadi kepada Bapak penanya, Bapak Yusuf, mudah-mudahan sudah terjawab pertanyaannya. So, is there any more questions? Is there any more? No? Yeah, okay. So, talking about loneliness is really interesting things, yeah. So, when we are growing up, maybe, yeah, we will do the same things. And of course, we have special treatment to prevent this one. And today, in the last session, Anny talked in a very deep about loneliness in the elderly itself. So, yeah, if you don't have any questions for webinar participant, maybe I will close this last session. Right? Okay, so but before I end this session, I will ask one more time to Ibu Anny, Rosiana, Masithoh to please give a closing statement, Mom.
Baik, terima kasih Pak Syafiq. Closing statement-nya ada bahwa Bapak dan Ibu, kita kalau sehat, insya Allah kita diberikan umur panjang, kita semuanya akan menjadi lansia. Dan di sini dibutuhkan sebuah kesiapan mental untuk bisa menjadi lansia. Jadi untuk menjadi lansia kita harus sudah siapkan mulai dari sekarang. Jangan kita persiapannya adalah nanti, mulai dari sekarang. Anak-anak sudah mulai kita siapkan. Anak-anak sudah mulai kita berikan contoh bagaimana kita merawat orang tua kita. Karena kita tidak hanya bisa menyuruh ataupun menasehati anak supaya berbakti, tetapi anak juga harus melihat contoh bagaimana caranya kita berbakti kepada orang tua kita. Supaya anak-anak juga bisa melihat, oh begini caranya merawat orang tua. Itu adalah salah satu persiapan. Jadi anak-anak juga sudah mulai harus kita siapkan bagaimana nanti supaya pada saat orang tuanya ini menjadi lansia, ini juga dia sudah prepare. Itu yang pertama. Yang kedua, secara finansial. Karena secara finansial lansia ini nanti sudah mulai masa pensiun gajinya berbeda, ya, dan pendapatannya juga sudah banyak berkurang. Ini sudah mulai harus kita siapkan dari mulai sekarang. Selain biaya-biaya untuk pendidikan anak-anak, ini juga kita sudah mulai harus safety untuk masa tua kita, ya. Jadi tidak semuanya mungkin untuk diprepare untuk anak-anak. Jadi ada yang harus dinikmati kita untuk di masa lansia. Yang ketiga, activity. Jadi mulai dari sekarang pun Bapak dan Ibu, mungkin usia-usia kita masih usia-usia produktif. Di mana usia produktif ini adalah usia-usia di mana kita masih bisa banyak sekali beraktivitas, eksplorasi, banyak inovasi. Kita sudah harus mulai berpikir juga di saat sedang siap sekarang. Apa yang akan saya lakukan nanti pada saat sudah lansia atau minimal sudah pensiun. Jadi jangan sampai stat kita ini terlambat, pensiun terus baru mikir. Tidak, harus mulai dari sekarang. Kita harus siapkan di masa lansia kita, supaya nanti kita tidak kaget. Dan yang terakhir adalah mental kita. Karena nanti secara physically kita juga mengalami degeneratif, ya. Tidak hanya fisik saja, juga nanti juga secara emosional, itu juga sudah mulai sensitif. Nanti juga ada demensia, dan banyak sekali nanti proses degeneratifnya. Kita siapkan diri kita, dan untuk yang saat ini masih mempunyai orang tua yang ada di sekitar kita, ini adalah sebuah kesempatan di mana kita belajar banyak bagaimana merawat lansia yang ada di sekitar kita. Jadi tidak hanya physically saja yang diperhatikan, tidak hanya makannya saja, tidak hanya minumnya saja, ya, tidak hanya mobilitasnya saja, tapi juga perhatikan secara psikologisnya. Seringlah ditanya, bagaimana perasaannya, apa yang diinginkan, ya selagi kita masih bisa, ya merekalah pintu surga kita, salah satu pintu surga kita, ya. Itu Pak Syafiq, terima kasih. Mudah-mudahan yang saya sampaikan bisa bermanfaat untuk semuanya, walaupun hanya sebentar dan sedikit.
Amin. Okay, so thank you very much again to Mrs. Anny Rosiana Masithoh for wonderful closing statement, and please give a virtual applause for Mrs. Anny Rosiana Masithoh. Right, finally we are in the end of this webinar series. So yeah, I would like to say a very bunch of thanks to our webinar participant along 4 series, 1, 2, 3, and 4 today. So you are still joining this webinar. And so this is a really a long and a very tiring process. So before I end this session, I mean, this is the last for this year of our webinar. I mean, so we would like to say thank you first to our Rector, Muhammadiyah University of Kudus, Mr. Rusnoto, for really supporting and guide us for this webinar. And then the second is to Ibu Anny Rosiana Masithoh as the Vice Rector. Of course, this webinar is holding under Mrs. Anny Rosiana Masithoh's department, and also all crews which is responsible for holding this webinar also. And very thank you for academic affair and also staff in our university and the webinar participant for a wonderful situation for this webinar. And finally, I am as the moderator, so I'd like to say expressing thank you once again for wonderful presentation and also collaboration from convener of Taipei Hospital and Taiwan International Healthcare Training for the collaborations to conduct this webinar, and also last but not least to Ibu Wara, who always support us for this webinar. So thank you all of you. Yeah, hopefully we work hard today so it can be beneficial for you us, and see you in a next series of international webinar series holding by Muhammadiyah University of Kudus. Thank you so much. Assalamualaikum warahmatullahi wabarakatuh.
Warahmatullahi wabarakatuh.